Morning and welcome, everyone. We'll give everybody a minute to get in today before we get started. And as we are having everybody come in, if you don't mind putting in the chat which organization you're from, and that'll help us know who's with us today. But your name, your title, and your organization, we would really appreciate seeing everybody. We thank you for joining us. And it looks like we've got everybody in. Got two more coming in. We'll get started in just a second here. All right. Well, good morning, everyone, and welcome to the 2025 Flex Financial Workshop. We're so glad you could join us today. My name is Chris Rowena. I'm the lead communications analyst with HCI Health Workforce, and I'm going to be your facilitator for today's sessions. This is hosted by the California State Office of Rural Health. And again, we're so glad that you've been able to join us today. This year's workshop is designed to help hospitals strengthen financial planning and compliance through a combination of informational presentations and one-on-one technical assistance consultations. We're especially excited that you've to provide dedicated support for rural and critical access hospitals, although today's event is open to all, and we're so glad that you're here with us. A couple of housekeeping items before we get started here. Today, we are in the Zoom meeting platform. You can find the controls, the toolbar at the bottom of your screen. In particular, I want to direct you to the chat controls and the Q&A controls down there. The Q&A and the chat are both open. And we would prefer that for technical questions that you use the Q&A, and for webinar related questions, use the chat. That'll help us kind of keep better track of your questions that are specifically technical related. But feel free to use it anywhere. You can also just raise your hand and wait to be called on. After each presentation, we will have a Q&A session for you to ask specific questions for each portion of the webinar today. We also are recording today's session, and we will have that. It says 5 business days there. This one's going to be 10 business days. We will have that up on our website for that. So encourage you to stay for the full workshop. We've got a lot of valuable information throughout the day. In particular, we're focusing on the seismic planning elements of things, but we'll be talking about financial data tools and rural hospital improvement. We've got a discussion about HPSAs and the Flex Care Grants, talking about the State Office of Rural Health, some updates there. We've got a great discussion from our OIS folks talking about the Open Data Portal and hospital financials. And then we'll talk about the SHIP program at the end of the day. And wanted to mention, if you haven't already registered for a consultation, we still have open slots, and so we would love for you to sign up for that, and we'll drop the sign up in the chat here shortly for that, for you to sign up. And you can get some one-on-one time with our amazing technical staff. And so we definitely encourage you to take advantage of that if you haven't signed up for that yet. We will be doing those through breakout rooms. And so as your time comes, you'll be in a breakout room will be opened up for you specifically, and you'll have the option to join that. You just go over to that breakout room. And then when you're done, make sure that you rejoin the session, close the breakout room, don't close the meeting. That way you don't get kicked out. And so with that, let's go ahead and get started with our first session. Our first presentation is on seismic compliance, and I'm going to hand it over to Ali Summer and Dean O'Brien from our OSHPD office, and who's going to walk us through everything there. So take it away, Ali and Dean.
All right. Thank you. Let me share my screen. Could you let me share just under request?
Yeah, I've approved it, Ali. It should go through here.
Okay. All right. Let's go to. Okay, here we go. Um, Today we're gonna go through a few topics. We're gonna start with seismic compliance plans. Myself and Haley will talk about that, and we'll turn to Dean to talk about the grant program. And then we will go into the details of the grant program. So before going into the grant program, we wanted to explain the overall seismic, how to put together a plan, because that's really a crucial part of financial planning. Like what is required, what's in front of you, what's the timeline, and how to put together a plan. And coupled with that, we offer support financially to reach that seismic goal. So I'll just quickly go through that. Let me put my laser pointer as well. Seismic compliance plan, a lot of people think about that like drawings and calculations and things like that. It's not that. It's basically um, an overall direction of which building in the facility require upgrade or some maybe downgrade. Basically, there are like two tables that we are asking, identifying those. And it's required from all hospitals. It's not just small and rural. It's all general acute care hospitals are required to submit that. And to help with that process, we have example spreadsheets. So we provided a link for you to look at, and there are like 9 examples in it. So these examples should really cover 95 or 99% of the time. The deadline to submit this plan is January 1st. There are 2 main tables in the seismic compliance plan. One of them is about, okay, let's say in your rural facility you have 4 buildings, and the first table asks, okay, building number 1, building number 2, building number 3, building number 4. For building number 1, maybe you need a structural upgrade. Building number 2, you want to relocate those services into a compliant building. Building number 3, you don't want to do anything because everything is compliant. Building number 4, maybe you want to demolish that. So again, these decisions that is going into this plan, we as a group, we help you to come to that conclusion. So we give you technical assistance in the small and rural hospital program to help shape your compliance plan. So you're going to see throughout the presentation that you're not alone in this process. Technical side, financial side, we advise you, we tell you about what options that there can be, what alternatives that you may want to think about, so that we help you to put together a compliance plan. It's easy to ask, okay, what are you going to do with the building? But again, there's so much in the background that goes into that decision. So to help with that one as well, the second table goes into the details of how you're going to achieve that. So what is the timeline? What are the steps? So this really helps shape the plan. So like think of like a little construction timeline, let's say. So this is kind of, it has 10 milestones in it that that basically lays down the fundamentals of how you're going to get there. A lot of times these are unknown, but we can basically advise you what are the industry standards on the timeline. So we can help you with that. And if things change, you can change later. So if this is something that is like we feel recent requirement. No, it's really not. This has been requirement since 1998. So the only thing that is changing is how you are submitting the plans. There's more information about the details of this. We have policy intent notice link here that kind of goes through all the regulations, some frequently asked questions, and so a lot of things are in here. So I'm not going to go through that one in this presentation. And also, I want to point out that there are more resources about step-by-step application process. So we have user guides on our website. So these are also live links. So if you click on this, I think everybody will get a PDF deck slides. When you click on this one, this will help you go through step-by-step process for the seismic compliance plan. So with that, actually, Haley will walk you through a couple other details about seismic compliance plan application.
So there's some information that we gather as part of the compliance plan application. The first bit of information is who is the owner of the facility. So we have some options. Those bullet point lists on the screen are the types of ownership entities that you can use from our dropdown. And then Ollie, if you would go to the next slide, then you can select whether the facility owner and the facility manager or licensee are the same entity. If they are, then you just need to enter the name again in the next line. But if you have a separate entity who is the licensee who's operating your facility, then you would enter that here. And then the last drop down is who's financially responsible for doing the seismic upgrade. Is it the owner or is it the licensee? Every facility has a different situation. So we're trying to gather those specifics for your facility. So that'll be the very first part of the compliance plan. So when you sit down to do your application, make sure you've got all that info handy. So as Ollie mentioned, there are two tables in the compliance plan that you'll need to fill out. This is kind of the meat and potatoes of the compliance plan. So the first table is a high-level view of your whole facility. We will have all of your general acute care buildings listed already, so they'll be pre-populated, and the SPC and NPC ratings will already be in there. And then what you'll need to fill out is what is going to happen with each building. So if the building is already seismically compliant, then you would click already seismically compliant. If that building needs an SPC upgrade, then you would click on SPC upgrade, or if it needs SPC and NPC, you'd select that. Or if you were going to be removing all of the acute care services from that building, then you would click on that. So this is sort of a high level view of what's happening in your whole facility, just one building at a time. So we have pre-populated options that say SPC and NPC retrofit. That's in that blue box on the screen right now. You could pick one of those. And then if you would like to add more information, there's a narrative box where you can type in a little bit of extra information for your reviewer. And then if you already have a project in progress that's related to that building, then we're requesting you put it in the compliance plan here in this box that says seismic compliance related project numbers. And that way we can track which ones, and also handy for you in the future when you come back to update, so we can keep all of the project numbers in one place. And then that last column on the screen, the HKI note, is going to be comments from us. So once you submit your compliance plan, we'll review it. And if we have a specific comment on that building or a request, then we'll put it in there and it'll show up under that HKI notes column. So this is that first table that is part of the compliance plan. And then the second table is a more zoomed in view of what you're going to be doing. So that first table has the whole facility and there's one line per building. The next table has 10 lines per building. And this is where it gets into the step-by-step of how you're going to bring each building into compliance. So just like the first one, we have some selected, or we have some options available for you to pick from a drop-down menu what those milestones are going to be. So you can pick up to 10 milestones per building. All of the milestone options are shown in that blue box on the screen there. And we have created some templates that will kind of help guide you for which milestones to pick. So if you're going to be doing, say, an SPC retrofit on your building, we have a template that has all of the milestones that make sense to go with an SPC retrofit. So you don't have to like guess on this or try to reinvent the wheel. We already have that kind of laid out for you. So you select your milestones, and then you need to select, you can also write a description if you have some more information to add about that. Like, for instance, say you were going to be removing the acute care services from that building and moving it to another building on your facility. In the description, you might say, we're moving these services to this building, just a little more detail. We also would like you to enter the completion date, so the anticipated date that milestone will be completed. A lot of these milestones are about submittals. So when are you going to submit the construction documents, or when are you going to submit to pull the permit? The date that goes along with that is the date that you're planning to submit. So put your anticipated completion date in there. We know some of the dates far out in the future are going to be a little bit of an estimate, especially those that are years out. And as Ollie mentioned, you can come back and change this. So if you're thinking it's going to be spring of 27, and that's kind of about as close as you have, once you get closer to 2027, you can come in and say it's actually going to be end of April 27, and you can sort of keep fine tuning. So for now, put your estimates in as best you have them, but you will be able to update those later. And then the status is what you put in as far as where that milestone is. So if it has already been completed, you already submitted that milestone, put completed. If you're in process of getting that, then you would put in process. And if you haven't started it yet, put not started. And in the future, when you come back to update your compliance plans, you can update these statuses to show that you are making progress. Same with the related project numbers here. If you have those project numbers, put them in. So if you have the construction documents project number already, you could put that in here. And then the HCI note, same thing as with our comments. And then the last thing is HCI determination. So we will also be marking your progress in here with met or not met. So once you've submitted your construction documents, then we'll put in there that milestone has been met. And then there's also one more toggle for that table, and that is critical versus regular milestone. So all the milestones will pretty much be regular, except for some that you go in and select as critical. So you'll need to have at least 10 critical milestones for your whole facility. And the purpose of these is to measure progress. So we want them kind of scattered across the whole plan. So if you're going to be done in 2030, that's another 4 years or so. So maybe you have them every 4 months or so, and try to pick milestones that are important, or ones that you really got to get done. As the name implies, critical, we're looking for sort of a high level. As long as we are meeting those milestones, we're pretty much on track for seismic compliance. And like I said, we want those spaced across your compliance plan. So if you submit your compliance plan and all the critical milestones are bunched up at the end or bunched up at the beginning, then we'll probably give you a comment saying, hey, please stretch these out across. And maybe we'll help you with suggestions, or if you would like help figuring out which ones are critical, you can call us and we'll help you sort through which ones would make sense to select as critical. All right, this is our gold mine slide of all of our resources. So we have a couple of webinars we've already done about compliance plan. The first one is more of like logistics of how you actually submit the plan and do the application, like use this drop-down menus, go to the next screen, that sort of a thing. So that's under previous webinars, that's the first one from March of 25. And then in August of 25, that is more about the content of the compliance plan. It has a little more info about the ownership part of it and the licensee part of it. And then we also have all of the examples that I mentioned. We have a template that has all of the milestones that make sense to go with each of the compliance paths that you might select. So if you have a building that is NPC 5 only, or a building that only needs an SPC retrofit, or if you have a building you're planning to demolish, pretty much any plan that you could possibly have is in this template and already has the milestones pre-populated in there. So I definitely recommend going to that template and figuring out which ones you should use and starting from there. Don't start from scratch. Don't start from a blank screen, because the first step is already kind of laid out for you in this template. So in that second webinar, I walk through each of those examples, each template, and tell you which ones are applicable to where and give some examples. So if you're not really sure where to start, or the compliance plan thing feels overwhelming, I would recommend watching that second webinar. And I think that will help you get your arms around what you need to do and also give you a really good starting point. So the link to the template is on this screen. Link to both webinars are on the screen. And then we also have an FAQ at the bottom. You can go check that out if you have a question. And also if you have a question, you can always call Ollie or I, and we'd be happy to help you figure it out. So the compliance plan also goes hand in hand with the AB 869 delay. So if you are planning to submit an AB 869 delay, make sure that your compliance plan and your delay application are submitted at the same time and that they're coordinated. They ask questions of each other. So the AB 869 delay is going to ask, what's your final completion date in the compliance plan? And when we review it, we're going to review them side by side. So make sure that those are coordinated and make sure you submit them both at the same time. The deadline for both of those is January 1st. So we have a couple more months to get those applications in. The AB 869 delay is a delay to the January 1st, 2030 deadline. So it's a delay to the final deadline. It doesn't give you a delay for the March 1st, 26 or the March 1st, 28 deadlines. It's just for the last one. The delay is only open to certain hospitals who meet eligibility criteria, which I'll go into on the next screen. We have a list. So this is kind of just a high-level summary of the eligibility. If you think that you might be eligible, I strongly encourage you to look at PIN 80. That it has all the details about eligibility, and it has a flow chart that kind of helps you get your arms around what we're looking at. But for the purposes of the presentation, I'll walk you through these bullet points. Oh, and I actually see a typo on here. There's a mistake. So the first sub bullet point, it says small or rural or district or recipient of DHLP loan. It should also say or critical access hospital. So if you're a critical access hospital, you also would meet this first bullet point. So in order to qualify for the delay, you need to meet all of these conditions. So the first condition is, are you small or rural or district or critical access or recipient of DHLP loan? If you have any one of those, then you meet the first criteria. The second criteria is that you submitted your NPC 4 or 4D and NPC 5 evaluations by January 1st. Oh, there's another typo on here. I apologize for that. It says 2024 is actually 2025. So if you submitted your NPC 4 and 5 evaluations by January 1st, 2025, then you meet that criteria. The next criteria is to submit your compliance plan and your delay application by January 1st, 2026. So that's coming up this January. So make sure you get those in by that deadline. The next criteria is that you actually need a delay. So if you're planning to be done with your seismic compliance in 2028, then you don't need the delay and the application is sort of irrelevant. The other thing that I'll add about this is that the window for delay that you can request is 3 years long. So you can request your seismic completion date be between January 1st, 2030 and January 1st, 2033. So your final compliance date will be reflected in your compliance plan. That's what we'll review, and that's what the delay will reflect, is whatever your final compliance date is. So make sure that your compliance plan completion date, final completion date is coordinated with your AB 869 delay application. And then the last criteria on here is that the facility does not belong to an integrated healthcare system with more than one hospital. So if you fall into that category where you have multiple hospitals or 2 hospitals in your integrated health system, that doesn't automatically disqualify you. It just opens up a new set of eligibility criteria, and those are laid out in Pin 80. I would recommend you go look at Pin 80 in the flow chart if you fall into that category, but you will need to meet all of these criteria to qualify for the AB 869 delay. And then at the bottom here, there's a user guide. That's the how-to, just the logistics of getting through the application, how to submit it. And then that link to Pin 80 is on this slide as well. All right, and then the last thing is that the compliance plans will be posted on our website. So all of the milestones that you select, all of the completion dates, which ones are critical, and also our comments on there will all be posted on the website for public viewing. Here's a couple screenshots of what it's looking like. We are updating it ongoing, so the visuals and the graphics will be changing, but this just gives you a little taste of sort of what it's going to look like. There's going to be a schedule that shows all of your milestones, critical, and which ones are being met and which ones are not being met. And like I said, all of our comments will be on there as well. And there'll be a status about whether your compliance plan has been approved or not approved. And if you're applying for the AB 869, if you're granted that delay, then there'll also be some info about that you've been granted the delay and your seismic completion date has been delayed from January 1st, 2030 to, say, January 1st, 2032. All right, and with that, I'll hand it over to Dean to kick us off for the Small and Rural Hospital Relief Program.
Thank you, Haley. Now that we know a little bit more about the compliance plan, here's how you're going to use it tangibly in a real way. Dean O'Brien, Deputy Director, HCI Health Financing Programs. Thank you for this opportunity to promote the funding opportunities under the Small and Rural Hospital Relief Program. Today, we're going to share some of the background on the program, tell the story of some of our recent collaborations, and ask for your help to get this grant money out of our accounts and into your communities. I'm going to kick things off with a high-level overview of the mission, administration, and who can participate in the program, and then we'll hand things off to my OSHPD colleagues who will dive a little deeper into the details around technical assistance and the award process. The purpose behind the Small and Rural Hospital Relief Program, or SRHRP as we like to refer to it, is to provide both financial and technical support to smaller hospitals often located off the beaten path. These facilities frequently lack the resources or capacity to move important seismic safety projects forward, resulting in work being delayed or not even started. This program was designed to address the significant resource constraints faced by hospitals in geographically and demographically challenged areas. It does so by creating a reimbursement mechanism that encourages these facilities to develop a viable seismic compliance plan, while also exploring all available options to optimize project scope and cost. So the SRHRP awards to small, rural, and critical access hospitals to assist them with meeting seismic safety compliance requirements. It was created by SB 395, which established an excise tax on electronic cigarettes, a portion of which supports the program. We're very proud to report that to date, every hospital that has submitted and fully completed the application with an eligible seismic compliance project has received an award. In terms of the administration, our team spans 2 offices at HCI. The financial and operational review and grant administration and documentation is administered by my team at the Office of Health Facility Loan Insurance, specifically Tom Winas, who's one of our account managers. And the technical assistance is administered by our OSHPD seismic compliance team, overseen by Ali and Haley. Our team meets weekly, and we review active applications, score any completed applications, and make recommendation on grant awards. Applications are accepted and reviewed, and awards are made on a rolling basis. In terms of who can participate, again, the eligibility check is pretty straightforward. Small, fewer than 50 beds, rural, critical access, and also it has demonstrates financial burden. There is no specific threshold in terms of days cash on hand or margin, but there is a statement in the application that the seismic work would impose a financial burden on the corporation. We also look if there's an imminent risk of closure in terms of determining the level of financial distress. And we like to make sure that we offer any technical assistance on the financial front if we are seeing that. We are currently working with we're tracking approximately 104 facilities that meet the criteria laid out under SB 395 and have been doing direct outreach over the last 9 months, including cold calls, warm introductions, and referrals. If you're curious if your hospital is eligible, please visit the SRHRP landing page where we have a complete list of all facilities that currently qualify. If you don't find your facility and think you should, please reach out. We have had a couple of facilities that weren't included that we were able to get added. With that, I'll pass things back over to my colleagues from the Seismic Compliance Unit who will speak more about the back-end process. Ali?
Thank you. So when we reach out to these hospitals, we basically our first approach is, okay, let's first identify what needs to be done. A lot of times, small and rural hospitals, they don't have the resources or the technical background like the ones that are like big chains like Kaiser, Sutters, and so we basically try to fill that gap with sitting down with the hospital, go through the requirements, what needs to be done, and what we have seen, what kind of solutions that we have seen based on the buildings that you have. So, and during that phase, sometimes there are like misunderstandings about what is required. Like if instead of a little retrofit, maybe in the past, a really big new tower was suggested with a huge dollar number. So we basically help in a sense that, okay, if you retrofit, these are the minimum things that are required to do. So minimum is important because I mean, if you want to do more, that's great, but we really focus everything on the minimum. And just saying that this is the requirement doesn't get the things done. So we basically not only help you identify the scope, but also we help you to review the costs of that minimum requirement. So it's not just one conversation, it's a continuous conversation. So we ask facility to share their contract if they want, and then we give feedback on the contract. Like, for example, there are some uncertainties in the scope, and then the contractor really adds a lot of unnecessary scope or markups or whatever, or misunderstandings. So we cut that fluff out. So we do a lot of cost reviews based on the scope, and that really helps focus not only the scope, but also the finances, the timeline, so everything shrinks down. And with that, we also help you, do the application. So, Haley sits down with the facility. Basically, we share screens. We literally help you fill out the form together, because it's not hard, but there are things that we want. So instead of going back and forth, we basically do it together. So, and once you do the application, once the money is allocated to do the seismic work, we also help you to be there in case of there are issues that comes up. So we will be with the facility throughout the whole construction to completion. So so again, if plans change along the way, we react to it. We maybe revise the application, revise the grant program. So again, please see us as a partner in this program, not just a regulation entity. So going a little deeper into some examples, we will be advising the facility, but also we directly collaborate with the whole team. The design engineers, the contractors, whoever will be involved, with the facilities permission, we contact with them, and we try to be the hub to basically eliminate any misunderstanding. If there's a scope already, an approved scope, we can go back and relook at what was approved and try to minimize that. So we do that a lot. We talk to the engineers. We talk about the spirit of the program. So every engineer that we chat with, they also really like the program. They help reduce the scope whenever there is possibility. A lot of times we do some phased testing to see if your building is in a good shape. If the initial findings are good, we kind of waive the rest of the testing so that it is more cost efficient. Sometimes the solution that is put in front of the facility is maybe not the most cost efficient way. So we share our past experiences with the design team to see if they can reconsider some of these things. Sometimes direction is changed. Sometimes they explain why, like, our idea is not a feasible idea. So we listen, but we do share some of our past experiences. So several times, actually, we end up finding something a little better or much better in terms of costs. So again, we are not compromising with the performance that is required. It's just there are many ways of doing things. Again, in this whole process, we are reviewing contracts cost and validating scope. So Haley will go a little deeper into the technical assistance.
Thanks, Ali. So the projects that are eligible for the grant. So as Ali mentioned, there's the grant part of the program and there's a technical assistance part of the program. If you have one of these projects, then you could be eligible for the grant part. So if you have an SPC2 building, then your options to bring it into compliance for 2030 are to take all of the general acute care services out of it and not use it anymore after 2030, or you could retrofit the building. If you're going to retrofit, that's called an SPC 4D. And if you're going to be doing that, then that project could be eligible for this grant. As long as your facility is eligible, that project would be eligible. So the grant will cover a lot of the costs that go along with that. It'll cover the initial evaluation, which is getting the engineer out there to look at the building and look at the drawings and do some calcs to figure out what needs to be done for the retrofit, what the state of the building is. The material testing part of it is also included as eligible scope. So the actual testing part of it, the lab, the contractor who comes out to patch up the holes afterwards, and again, the engineer's fees that go along with that. The geotechnical report, if you need to update a geotechnical report, the costs associated with that would also be eligible. And then the design part is eligible. So the engineers and architects, or if you were to need another type of engineer involved, then those costs would also be eligible for them to develop the drawings. And then the construction costs are also eligible, and the costs that come along with construction, like inspection fees or lab testing fees. And then the engineering and architect fees that go along with construction, those also are eligible. So most of the costs associated with the SPC 4D retrofit are eligible for the grant. And if you are doing an SPC 4D retrofit on your campus, then the NPC design and evaluation fees can also be eligible for the grant. So if you have one SPC2 building that you're going to be upgrading, you can also request reimbursement for the NPC engineering and architect fees that go along with that. The construction for NPC is never covered, but it can, the design and evaluation can be if you're doing SPC 4D retrofit. And if you're not sure which path you're going to do, if you have an SPC2 and you're thinking maybe we need to build a new hospital or we're not sure, then you should look into the grant for the evaluation phase, because you can get a lot of the cost of that reimbursed, and then you have much better information at your fingertips about the actual state of your building and what it would take to retrofit. And you can do that, like I said, with a lot of the cost being reimbursed. So definitely recommend reaching out if that's the situation you're in. We'd love to help you through that and get you started with a grant application. So the next slide is what's not eligible. So scope that's not related to seismic compliance work is not eligible. So we understand that it makes sense to kind of lump multiple projects together under one contract. So if you want to do your seismic upgrades, your SPC 4D work, but also want to give your imaging department a little facelift or whatever other project you have brewing, we understand that it makes sense to do those together, but only the seismic part of it would be eligible for the grant. And if you're going to be doing that, then we'd be happy to work with you on that. And we'll just have to make sure that the cost estimates keep those projects separate, so we know which part is eligible for the grant and which part is not. New buildings or new additions are not eligible for the grant. Like I said, it's only that retrofit option. So if you have an SPC2 building and you're going to be retrofitting it, that's eligible. But if you have an SPC2 building and you're going to be replacing it with a new hospital or a new building, then that would not be eligible for this grant. Same thing with demo or removing acute care, those are not eligible. And if you're a facility that's only doing NPC 4 and 5 work, so if you don't have an SPC2 building that you're retrofitting, then right now the grant doesn't cover that. If it changes, then we'll definitely be putting that information out there, and if that grant eligibility gets expanded. But for right now, NPC only facilities are not eligible for the grant. But I would like to say that just because you're not eligible for the grant part doesn't mean you're not eligible for the technical assistance. So if you are doing NPC only work, but you have questions or the scope seems really big and you'd like us to help you review it and you're small or rural or critical access, please reach out to us. We'd still love to meet with you, and you can still get benefit from the program even if you don't get the grant. Right. Oh yeah, this is what everybody wants to know, is how much money do we have left? We have about $52 million left that have not been allocated for any hospital yet. So lots of money still available. We get about $2.6 million a year additional. We have already given out 9.5 million in grant awards, or at least allocated them. So it's a reimbursement program. So once you meet your milestone, you do your construction drawings, say, and you send them in to us, then you can also send in all your invoices that were associated with construction drawings, and we will reimburse you per the grant. So we have $9.5 million that we have allocated for the hospitals on the list there on the right. And we have $4 million that is kind of brewing. So we were talking with other hospitals about new potential grants, and we have $4 million there. The grant program also comes with a lot of flexibility as far as how we award. So you don't have to know how much every step of your compliance is going to cost in order to apply for the grant. So if you are starting at square one and you are just going to do your evaluation and from there we'll see, then we can do a grant for just that first step. And once you get that first step done and you have a better idea of what the next step looks like, we can apply for another grant and give you another award. And so the grant program can kind of follow along with the schedule and the steps that you have for your hospital. So for instance, there's a couple of hospitals on this list. Community Memorial Hospital, Ojai, just got their second award for their next step. And George LME also has a couple. So, and these facilities may also have more. There may be award number 3 or number 4 as they progress through their seismic compliance. So I hope that makes it more approachable. We want to work with you and meet you where you're at and help you figure out what that next step is. All right, next slide. So here's the upcoming seismic compliance deadlines. The January 1st is coming up quick. That's for the compliance plan and the AB 869 application. And then right after that is the deadline for construction drawings for NPC 4, 4D, 5 retrofits. Also, if you're going to be doing demo or a RACS project, the construction documents for that are due on March 1st, 2026. And then the next deadline will be 2 years after that for obtaining building permits for the same NPC 4, 4D, 5 RACS or demo projects. And then the final one is January 1st, 2030. And that is when all the GAC buildings need to be compliant for both SPC and NPC. On the next slide, we have, I believe, our new resource for the timeline. Yeah, so we have this new visual aid to help explain the deadlines and also give some more information. If you haven't already downloaded this timeline, I recommend that you do the links on the slide here. And it has everything that is due for seismic compliance between January 1st, 2024 and January 1st, 2030. And each deadline has a little blurb about who that deadline applies to. So you can see if you are exempt or not. And then it has resources. So usually there's a webinar, a user guide. Sometimes there's a pin. There's lots of resources linked in for each deadline. So if you're not sure what's next or what's coming, or you have some confusion, or you just want all the resources in one spot, recommend this timeline for sure. And if you're considering that AB 869 delay and wondering if you're eligible and you need to go through that, this timeline also has a checklist of the things that you'll need to consider, links to some of the eligibility lists, and the link to PIN 80. So I definitely recommend downloading this timeline, at least for the convenience of having all the links in one spot. All right, here's our contact information. Like I said, we'd be happy to talk to you if you have questions or you're feeling stuck on your compliance, or you would like some assistance moving forward or with the grant. Please reach out to us. There's Dean Ollie's and my contact info. And with that, I think we may have time for questions. I'm not sure, Chris.
Yeah, thank you, Ali, Haley, and Dean. Very informative overview, and thank you for all that you do to support California's hospitals. We do have time for questions, and so we've got 3 ways for you to engage with us today. Make it easy. Pick whichever one is easy for you. You can raise your hand, and we can call on you. Or if you want to type in your question, you can either use the chat or the Q&A. We've got about 10 minutes for questions if we want it. So go ahead and raise your hand if you've got a question, or type it in. Definitely appreciated the very thorough overview of all of the programs that you have. All right, and we've got a comment in the chat here. Let's see, just a reminder, the slides and the recordings will be available to all registered attendees within 10 business days. And we've got the link to that seismic compliance plan timeline that Haley mentioned. Thank you for getting that in the chat, Eddie. Wanted to also mention that we still have room for people to sign up for our consultations. And so if you haven't done that, we will drop that in the chat again, but you can see, I think everybody was here from since we've done that, so you can click on that Sign Up Genius link and go ahead and sign up for one of those. Any questions for our team on the seismic compliance? About 30 more seconds here. All right. Well, looks like we don't have any questions at this point. If you think of one later, we will be here till 2 o'clock, and you can enter your questions into the chat or the Q&A, and we'll be able to help you out. Or again, you can sign up for one of those consultations, or you can always email us and get a hold of us afterwards. And so, again, Haley, Dean, and Ali, thank you so much for just a wonderful presentation. We appreciate you. We're going to go ahead and take our first 5-minute break here. And so, and then we will come back with our next presentation on HPSAs here in 5 minutes. So thank you, everyone. And get up, stretch your legs, quick bio break. And we've got a long day ahead of us. So we want to make sure we're giving you plenty of opportunity to stay refreshed and ready to tune in. So we'll see you in 5 minutes. All right, we're going to come back. And before we get started on our next one, I got a quick poll for you all on this seismic compliance topic. Wanted to know what type of support would be most helpful in the future in regards to seismic compliance. We've got the choice of technical assistance with compliance planning, help identifying financial loan options, clarification on regulations, timelines, peer examples, case studies. And you know what? We're good. So go ahead and fill that out for us. That'll help us know where we can continue to support you best. We appreciate you. And we're going to get ready for our next presentation coming up here. We've got Darby Moss is going to be joining us. He's going to provide an overview of the HPSA designations, a health professional shortage area, and explain how they're determined, how to share these designations, help guide federal and state program eligibility. So thank you for participating in the poll, and I'm going to hand it over to Darby.
Very much, Chris. Thank you, everyone, for allowing me to talk about the health professional shortage area designations, or as we say, HPSAs, and their benefits. Before I begin, I would like to take a couple minutes to tell everybody about the California Primary Care Office. Our office works with stakeholders from the community to get areas in California designated as HPSAs. We do this by collecting information, analyzing it, and submitting it to the Health Resources and Services Administration. Our office also provides technical assistance for HRSA's National Health Service Corps and Nurse Corps programs. We'll be discussing those two programs later in this presentation. Next slide. So the first thing is, what is a health professional shortage area? A health professional shortage area is a designation based upon the evaluation of criteria established through regulation by the Federal Health Resources and Services Administration, Bureau of Health Workforce, to identify geographic areas or population groups with a shortage of primary, dental, mental health care professionals in a medical service study area, or what we call an MSSA. So the medical service study area is a term that is done or that is used by California, and it is one in which we define an area as a grouping of census tracts that are within population limits and are limited by county boundaries. They're whole, and so they cannot have holes within them, such as a donut shape or anything like that. So those are the areas that we look at when we're talking about trying to designate an area as a health professional shortage area. So in this case, when I'm talking to the critical access hospitals, I just want to make it clear that there are only two not located in a HPSA. Those two are Community Memorial Hospital, Ojai, and Healdsburg Hospital. And if one of those people representative from one of those hospitals is here today, please go ahead and reach out to us. There will be some contact information at the end of this presentation, and we could take a look and see if we can get that area designated. I also want to point out that the California Primary Care Office is currently reviewing and updating HPSA designations. Again, if you think that your area needs an update, then please reach out to us. We could always work with you. We could tell you yes, no, and move forward with that. Next slide, please. So there are lots of benefits of having a HPSA designation, and we're really going to focus on that today, since most of the CAWs already have a HPSA designation. So one of the major benefits is to help your hospital with recruitment and retention. So with that first one, the NHSC loan repayment and scholar placement program, we're going to go into that one a little more in depth later in this presentation. The state loan repayment program is actually a program where we get federal dollars from HRSA, but those dollars are distributed through our office and through HCI, through our state loan repayment program. So that is not something the primary care office does, but we could definitely point you to that program and you can get more information about that. The Nurse Corps loan repayment is another program that's run by HRSA, and it's another program that we oversee, and I'll get more into detail about that in a second. The Office of Health Workforce Development, Loan Repayment, and Scholarship Programs, we have a bevy of programs that can be tapped into, all the way from behavioral health to nursing to physician, scholarships, grants, all kinds of things. And a lot of these utilize HPSA designations. Another great program is the J-1 Visa Waiver Program. The J-1 Visa Waiver Program is for people that are foreign-born that come to America to complete their residency programs. And after that, they would like to stay here in order to practice. If not, they would have to go back to their home country for 2 years and then return. So this waiver application allows them to stay here. This is a great thing for hospitals. If you can recruit a J-1 visa waiver applicant, that will allow you to have them for at least 2 years. But there's also an opportunity for them to apply for a national interest waiver. And that national interest waiver is a 3-year commitment. So what you're looking at is really a 5-year commitment from that doctor to come into your community and hopefully make a real impact for you. We have a J-1 visa waiver coordinator in our office. And again, we could help you get with them to get more information about that. Another thing our office can help you with, and a benefit, is the expedited medical licensure that we can help with the Medical Board of California. We can provide you a letter of support to help any of your physicians expedite that process. The financial benefits are we can help with a rural health clinic or RHC certification. There was also the 10% Medicare bonus payment. And this is for all kinds of facilities and clinics and things like that. But it does not apply to FQHCs or RHCs, and it's a geographic HPSA only. I will explain that in more detail in a second. And then lastly, our registered dental hygienist program is also something that we can help with. We have a specific expert that can help you in that area. Again, if you just contact us, we can help. Next slide, please. Okay, so this slide, I want to start on the left-hand side with the designation type column. So the designation type really helps you understand what our office does. So we work with primary care HPSAs, we work with dental care HPSAs, and mental health care HPSAs. And these are broken into different areas. So we have what they call the area, which you see on the top there, or we call those our geographic HPSAs. Those are usually like our straight population to provider ratios. The population, we're looking at the low income populations using our 100% federal poverty level numbers, and also the 200% federal poverty level numbers. So that's more looking at a isolated population. For dental care, you can look at both population, geographic areas. Mental health, again, is specifically, we can look at is geographic population. Now, the other one here at the bottom, the second one from the bottom are facility HPSAs. These would include any of our correctional facility HPSAs. This would also include any kind of HPSA that doesn't qualify, like if your hospital or your clinic doesn't qualify, but you can show a need that you are serving an underserved population, then that might fall under a facility HPSA. And then lastly, we have what we call our auto facility HPSAs, or that is our FQHCs, our RHCs, our tribal health clinics, things like that. Okay, so moving across here then, talking about the benefits, you can see here the NHSC programs and the SLRP programs can apply to any of these types of HPSA designation. The one that is the one that a lot of people talk about the most is the next one and want to know about that Medicare incentive payment. So that is only for the primary care and the mental health designations, and only for the ones that are geographic based or area based. The rural health clinic certifications, that's only for primary care. And then again, I really want to stress the how great this J-1 visa waiver program is. And you can see it can apply to any of these designation types except for dental. The OHWD programs that we have in-house will apply to any of them except for facility and auto facility. And the priority licensure, again, can apply to any except for dental. And then our RDHAP program can then apply, obviously, to dental, since that's the only one. So you can see here, we provide lots of different opportunities, lots of different benefits to people that are in HPSAs. And that's kind of a bulk of the work we do, is we try to get that HPSA, but we also want to know, or want to make sure our stakeholders know all about the wonderful benefits, and then connect them with the correct people and correct programs that can get them those benefits. Next slide, please. Okay, since the National Health Corps is one of the programs that the primary care office oversees, I really want to go more into depth with this one. So this was created to address the growing primary care workforce shortage. It offers scholarships and student loan repayment in exchange for a service commitment to practice in designated health professional shortage areas. And the provider must serve in a HPSA that matches their discipline. And so, you know, if you're a physician, you need to serve in primary care. If you're some sort of behavioral health, again, mental health, and obviously dental and dental. Next slide, please. So the National Health Service Corps, there's two pieces to it. There's a piece of, you have to get a site approval first before you can have any kind of participation with your providers. So you have to actually go through an application process. You have to get that then done and approved by the National Health Service Corps. While some types are automatically approved, CAUSE are not, and they must apply during the application window. And the application window is typically open during the spring of each year, kind of late spring into early summer. And really, the benefits of that, again, is recruiting, hiring, retaining qualified clinicians. In terms of like recruiting and hiring, I was working with one individual in his clinic, and he was telling me, Darby, this is so important to me because I had 4 applicants, and they told me they will not accept an offer from me unless I can offer them. Our providers out there know about these programs, and they want to be a part of them. Next slide, please. So, in terms of the National Health Service Corps, again, they really can provide any kind of loan repayment options. So, there are definitely benefits to using this program, maybe that are different than other loan repayment type programs. So one of those is it is very flexible in terms of you can do a full-time clinical practice, you can do a half-time clinical practice, and then it is obviously different in terms of the award amounts. You have a full-time service with up to $75,000, and that is for primary care providers only, or $50,000 for all providers for a 2-year initial term. And then a half-time is half of that, or for $37,500 for primary care, or $25,000 for all providers. Now, you can complete a repayment of qualifying loans program, and this occurs after the initial 2-year service contract. So you can then have a provider apply again, and they could keep trying to pay off those loans, but that only occurs once they've completed their initial 2-year service requirement. Next slide, please. So for the National Health Service Corps Scholarship Program, this is one that a lot of hospitals and clinics will try to recruit someone coming out of these loan repayment programs, out of these scholarship programs. So it awards, the program for students, though, is allowing them to gather or to gain funds while they are still in school, so long as they are pursuing an eligible training or degree program for any kind of primary care health profession. And then in return, the National Health Service Corps says, we will, or in return, you have to work in an area of high need, okay, in a HPSA. Now, I really want to point out here that when they say high need, that's exactly what they mean. There is a 0 to 25 score for each HPSA, 25 showing the highest need, and they want them in usually scores of 19 or above. Again, so that they know that they're being in areas of the greatest need in our country. So just so you understand a little bit more about this program, they will pay full-time enrollment in an eligible degree or training program. They will support for 4 years of schooling, the payment of tuition and the eligible fees. They'll get an annual payment for other reasonable educational costs, and they actually get a monthly stipend to assist with living expenses while a student in school. And I really wanted to include this just because I want to show you how much the National Service Corps is willing to invest in a scholar in such a great program like this. And that's why then they ask them to go serve in those really high needs areas where the underserved populations need providers. Next slide, please. Okay. So this is another program that HRSA puts on or offers. And it's not as well known. And that's why I want to spend some time talking about it today. So the Nurse Corps programs offer help to address the shortages of nurses across the country. And we all know this is such a big problem. And the Nurse Corps will offer loan repayment to nurses who work in healthcare facilities experiencing a critical shortage of nurses. They also offer scholarships to students enrolled or accepted for enrollment in nursing degree programs. And here's where it really differs is that nurses can serve in either primary care or mental health HPSAs. So they are not limited to their discipline when they're applying for the Nurse Corps. We will go into more of the loan repayment side of this. Our office doesn't do a lot with the Scholar program. So I really want to hit on the part that we know best. Next slide, please. Okay, so the loan repayment to nurses who work in these healthcare facilities experiencing a critical shortage of nurses. So you'll see that wording, the critical shortage of nurses on their website. You'll see, and what they mean by that is a HPSA. Okay, so that's how that critical shortage of nurses is defined. Even though they're not coming out and explicitly saying HPSA. And again, the other unique part of this is nurses do not have to be working at an approved site. So unlike NHSCs, where they have to go through an approval process, that is not the case for Nurse Corps. They just have to be working at a site that is either a primary care or mental health HPSA. And I want to go back to my original note that there are only 2 hospitals, critical access hospitals, that do not have a HPSA. So each one of those hospitals that do, they either have a primary care or a mental health, or they have both. So Nurse Corps would apply to any of those facilities. There are great benefits. The Nurse Corps will pay up to 85% of the unpaid nursing education debt in exchange for at least 2 years of service at one of those eligible healthcare facilities that are in HPSAs, or eligible School of Nursing. So they will, it really is a beneficial program to help our nurses. And then the nurses that can apply are registered nurses, advanced practice, registered nurses, or nurse faculty. So the nurse faculty, this is already kind of a not so well-known program. And then within this, really nurse faculty is the one that's kind of hidden in here. So a lot of people don't know that you can actually apply if you are faculty and not necessarily practicing nurse at that moment. So please get word out about this program. If you are a hospital, again, a lot of them are having nursing shortages. Please reach out to us. We would love to tell you more about this program. I've only hit this at very high levels, and we can then get you all the information for applying to this program. But this is a program that I think is very underutilized. Next slide, please. So thank you for attending this presentation today. For further questions, I've referenced this multiple times. Please reach out to the California Primary Care Office. We have a a box that is checked by multiple people. So we will get back to you in a timely manner. The email address is shortage@hchi.ca.gov. I would love to take any kind of questions at this moment if there are any.
Thank you, Darby, so much. Let's go ahead and go into some question and answer time. We've got about 9 minutes that we can use to answer any of your questions regarding HPSAs. So go ahead and raise your hand down at the bottom, or you can type your questions in to the chat. And Darby, we appreciate all of that great information that you provided for us today.
Absolutely.
While you're thinking about your questions, I've got another poll for you. And so continue to think about any questions you have for HPSA. And we have a question for you regarding HPSA. So this one, similar question poll as last time. What would help your organization most when it comes to HPSA designations? Guidance on eligibility and process, data and mapping support, staff training and technical assistance, or we don't need any support. And while you're thinking about any specific questions you have for Darby, go ahead and take that poll for us. Keep the poll open for about another minute here. Any questions for Darby on HPSA designations? All right, let's go ahead and show the results on the poll. It's like definitely need to continue guidance on eligibility and process. So I encourage you, if you have any specific questions while you have Darby, let's if that's an area that you have a question, go ahead and ask it right now. And then we've got staff training and technical assistance. Looks like the other area where help is needed. So again, we've got a few more minutes that we have available for Q&A with our timeline today. So if you have a specific questions on guidance for eligibility and process or staff training and the technical assistance that's available, now is the time.
Absolutely. And I would encourage those questions still. I would also like to mention that we do hold biannual workshops where I went through this very quickly, but we spend a couple days going through the entire process and meeting one-on-one with stakeholders, looking at their situations and how we can help them. So we'll have another one of those coming up in the spring, and then we'll follow that with fall of next year. So if you want to be part of those and you're not already on our sign up, please use this email on the screen, and I could get you more information about those two workshops that we put on.
All right, thank you, Darby. Is there a link that people can sign up for more information or get more information about the spring designation workshop coming up, or are we still waiting for that to come out?
We're still waiting for that since we're in the initial planning stages of that. But the best thing to do is always to get on our listserv for that so that we can get you that information as soon as it comes out. And again, use this inbox, the shortage@hchi.ca.gov. We would love to put you on that email, and so that you'll be the first to know and get signed up and be able to join us. We love when people join us, and we can really go more in depth on everything.
Fantastic. Thank you, Darby. All right, let's do last chance here for any questions that you may have on HPSA designation. Don't be shy. We can use your chat feature, or you can raise your hand down at the bottom of the screen. I ask everybody right now to enter in your name, your title, and the organization that you represent in the chat. We didn't get that at the beginning, and so if everybody can go ahead and do that, that would be a great way for us just to make sure that everybody is with us and that the chat feature is working and helps us know who everybody is as well. So go ahead and down on the chat button down at the bottom there. Enter in your information. We would really appreciate that.
Lastly, I am going to drop a couple links in there for those different programs. NHSC has a lot of different programs, but I've only highlighted a couple. So in this link, you'll be able to kind of go in and look at different ones.
All right. Thank you so much, Darby. All right. Seeing some participation in the chat. Janet, thank you. Welcome from Tahoe up in the mountains. And we've got Michael from the High Desert Medical Center facilities. Thank you for joining us. Jennifer from the Mountain Communities. Appreciate you being with us. And Kelly from Inyo Healthcare. Awesome. From Lone Pine. You guys all live in beautiful parts of our state. I love that. And Rebecca, we've got Rebecca from Mountain Communities and Tim from Catalina. Oh, how fun. Catalina is a great place. Wow, you guys live in the best parts of California. That is amazing. All right. Well, we are getting set up here for our next presentation. Cameron, also from Catalina. Thanks for joining us, Cameron. Again, Darby, thank you so much for your participation. And next, we're going to shift our focus to the Critical Access Hospital Care Grants, key funding opportunities supporting California's critical access hospitals. Our next presenter, Lisa Garrity, will share details about the care grants for critical access hospitals. And I'm going to go ahead and hand it over to you now, Lisa.
Good morning, everyone. Hello, thank you for that introduction. As was said, I am Lisa Garrity with the California Hospital Association. I've worked at CHA for about 10 years now, and I joined onto the FLEX program administration in 2017. Next. Today, I'm going to talk to you about the Medicare Rural Flexibility Program. We'll talk about the eligibility, the grant fund process, including applications, topics, responsibilities, and expectations, as well as the reporting. Next. The Medicare Rural Hospital Flexibility Program aims to improve healthcare access and quality in rural communities. It is federally funded and administered by the State Office of Rural Health, which is a division of the Department of Healthcare Access and Information we all call HCI. Who's also hosting our meeting here today. Each state FLEX program has the discretion on how to utilize the funds as long as the state program operates within the federal guidelines. There are 45 states participating in the FLEX program. Next slide. FLEX doesn't operate on a traditional calendar year. Each FLEX grant cycle begins September 1 and runs through August 31st. First quarter activities include the grant getting approved by the federal government and funded to State Office of Rural Health. And then an agreement is put in place between the State Office of Rural Health and CHFT. CHFT is the grant division of CHA. The CHFT engages 2 subcontractors, and then a kickoff webinar is set, which if you have been at your critical access hospital for a while, you may have gotten invited to past year's grant kickoff webinars. So we will get that set up at the end of first quarter around that time frame. And then we move into the second quarter when the grant kickoff webinar will typically happen. And we'll immediately following launch the grant application period. And then the grant review team will review all of the applications submitted and notify the applicants. And then the contracts will be put in place for those successful candidates. We roll right into Q3, where your grant will be actively in progress at your facility. And there will be an interim report due at that point, sometime during Q3. During the last quarter of the grant, the project should be reaching their final stages. And then a final report with project receipts will be due in the first days of September. In addition to these quarterly activities, there are also annual activities, including opportunities for all of the critical access hospitals in California to join virtual monthly meetings on quality, MB-QIP, technical assistance and training, QAHI administration management and training, EDTC data collection and follow-up. All critical access hospitals will have that opportunity to request an in-person at the hospital process operational improvement session. And then there's also the annual quality in-person workshop here in Sacramento, where 2 staff per each CAW can attend, and most of the costs for you to attend are covered by the grant. Next, please. Next, let's discuss CARE grant funding and eligibility. Going clockwise and starting from the top, and I apologize for the small size of these slides. Once the contract is in place between the State Office of Rural Health and CHFT, the grant application cycle then opens up, and all critical access hospitals participating in MB-QIP can apply for one grant up to a $15,000 limit request and related to one or more of the flex topic areas. I must stress that this is a competitive grant process. In recent years, the grant interest has been greater than the funds available, so there is no guarantee to get your funds for your project. Projects that are in progress must be completed and all funds dispersed by August 31st. Go ahead and go to the next slide, please. As you think about projects you'd like to complete at your facility, please note for the FLEX program, your planned project can be any improvement you want. As long as you are a California critical access hospital, you're participating in reporting MB-QIP, and the project falls under one of these categories with measurable data results. There must be at least one quantifiable measure included in your application. Next slide, please. So what kind of projects might you want to do at your hospital? I can give you some examples. In QI, recent QI examples of improved projects include translation devices to improve HCAHPS cleanliness scores. Pardon me. A quiet app on staff phones that monitors sounds and alerts staff if a certain level is reached at night. Another successful grant implemented discharge improvement tool to improve their HCAHPS scores. And then we also had an ED throughput project where the goal was to reduce the ED length of stay from 250 minutes to an average of 150 minutes. These are just ideas if you're looking for someplace to start, not a requirement. Next slide, please. Here are some examples of population health improvement projects. Putting up a tent at local events and offering free blood pressure checks, followed by an opportunity for continuing care if needed. Renting a mobile mammography van for those who can't travel to their annual screenings. Addressing cancer screening rates by hosting webinars, sharing materials at community events. A recent hospital addressed this in their area and they were able to increase their county mammogram completion rate by 11%. The last example I like to share, it's very niche, it's unusual, but it was a very effective project. So I share it as a way to think outside the box. A few years ago, a critical access hospital in California was donated a building, and they weren't quite sure what to do with it, but they had a high number of people being diagnosed with diabetes. So they decided to convert it to a training kitchen. And they took a group of people who had recently been diagnosed with diabetes. They took them to grocery stores and showed them the best places to shop in a grocery store to buy fresh, wholesome foods. And then they did training sessions teaching them how to cook those foods and make healthy meals for their family to try to manage their diabetes that way. So, great project, something to think about if you're looking for something a little bit different to do your project on. Next slide, please. A hot topic these days is financial and operational improvement. I'm sure we could all use a little bit of that. A couple of examples I can give you from the recent history of the grant. We had one hospital hire a third party to work with their hospital physicians to complete credentialing with health plans, thereby decreasing their payment delays and denials. The goal they had on their project was to go from current 17% enrollment to 70% enrollment across health plans. They were able to achieve that goal, and post-project, they let me know that they continued to work on the other 30%. Not a requirement of the grant, but it's always nice to see where the projects go once the grant cycle is over. Another facility noticed that once they implemented a new EMR, that their days in accounts receivable shot way up. They went from 53 days in AR up to 82. They root caused that as being due to a lack of training, which led to coding errors. So this hospital employed a consultant. They brought him in to do training sessions with the staff. And in their final report stated that this has alleviated staff frustration, and it was helping them to slowly rectify their days in AR. I call that a double win. Next slide, please. Here are some keys to your success. I will read through them and then talk about them a little bit. So please make sure all your requested information is completed. Make sure the problem is clearly identified with a reasonable solution plan. You should have a feasible timeline and well-detailed project activities. And don't forget those data-driven initiatives. Those are important. And then make sure you have a team that's going to be dedicated to the success of your project. I would like to mention again that this is a competitive grant process. We might not be able to fund or fully fund all applications. There are currently 37 critical access hospitals in California. Prior to 2020, about a third of them would typically apply for this grant each year. And in the last 2 years, we've had 23 and 24 apply respectively. So that's up to 2/3 of the hospitals applying. I don't say that to discourage you. There's a lot of great project ideas out there. Just want you to know that sometimes there isn't quite enough money to fund everything each year, and I want you to submit your best project to the group for their review. Next slide. Now let's review the application itself. You are the lucky group of first hospitals, other than our testers, to get to see our new virtual application form. Previously, the form was written or typed in Word and submitted via email. Those of you who have applied in the past will see the requested information remains the same on the application, only the method of submission has been updated. The Going through the top, reading through the top, we talk about funding and eligibility requirements. A lot of this is stuff we already talked about, like maximum request of $15,000, using a quantifiable baseline measure and goal, the competitive part of the program. The dates on here are just placeholders. We don't have our contract quite in place yet, so I can't schedule the kickoff meeting, but the second we can, you all will receive those invites via email. I also have the number one question on here. This is different from the original form. You used to just write in your city and have to write out all your address details. Instead, we've streamlined that and created a drop-down with the city of each critical access hospital in the drop-down. So you just scroll through, find the city of your hospital and select that, and you can move on to the next question. Next slide, please. All right, so you can see here, these are the first 11 questions that you'll be asked. Questions 1 through 6 are the typical personal information to the hospital and you. We did add a verification email section in here to make sure we got that email address right. Top of this second page, this is actually one page on the application, but you have your funding requested and total project cost. And then it's very important is your project focus. So you'll want to select one or more topic. You're not required to have more than one, but sometimes projects span the scope of more than one area of Flex, and you're welcome to check both of those off. Please note, if you select more than one, you have to also include a quality measure, not a quality measure, a improvement measure for each one that you check on this question. So keep that in mind when you're picking your topics. Next is your project title, which is completely up to you, whatever you think best describes what you're going to be doing. The next question is, you just telling us what problem it is you're trying to solve at your hospital. Somehow I missed putting question 12 on here, which is where you're going to give a project overview. This is where you get into the meat of what you want to do, what you want to accomplish in your project, and how you're going to do that. Next slide. The next question on the project is project activities, work plans, and timeline. This section is for listing each of the project activities in chronological order. It's applicant's discretion as to the level of detail. Each activity will have a person assigned to a task, along with a start and end date. Only 3 activities are shown here for the purposes of the presentation, but there are up to 9 spaces for activities available when you go into the actual application. While every little detail doesn't need describing, later in the presentation, I'll go through a sample application that you can use as a guide of the detail level if you have any questions on how to fill out this section. Next page, please. So the next page is going to take you through each of the topics so you can select the one that you want. Starting with quality improvement. Now, I believe most of the people on this call webinar are CFOs, and I'm not sure if you see the HCAHPS reporting and scoring at your facility, but QI projects are frequently focused on improving various HCAHPS scoring. If the answer to question 14 is yes, then the measure page on the right will be what you see. But if you're not doing a quality improvement project, you would select no, and then the detail page on the right that you see here on this screen will be skipped, and you will pop to question 18, is this a financial improvement project? Since this group is primarily financial focused, let's skip the measures here, and I'll go into more detail on the financial improvement page. Next slide, please. All right, so Next one, project improvement measure. Is this a financial operational improvement project? Same format as the last page. Excuse me. As previously stated, I'm sorry, I lost where I was. I circled here an example of what your measures might look like. I think you can read these, but I'll read them to you. So just as an example, a measure of days revenue in AR, your baseline might be 102 days in second quarter of 2025. And maybe by the end of the project, you want to have your goal down to 85 days. So you would fill that in on question 19. As I said, you're only required to have one measure. You can put in up to 3, whatever works best for your project. Next slide, please. So the next one is the population health page, and you would fill out the exact same information if you have a population health project, or when you hit no, you'll be taken to the next page, which moves us right into our budget section. Next slide, please. Given the length of the application and this presentation, I've only shared one of the sections, and that's the supplies budget shown here. Please know that there are several additional budget sections to include those shown at the bottom of the screen. For each of the listed sections, there will be the same line item breakouts that you see on question 26 to include a description, the funding requested, any funding that you might be providing from other sources, and the total of that small section. Next slide. Earlier, I mentioned not finishing the survey and how to do that. Not shown on the slides, but you can scroll to the bottom of each page, hit next until you get to the next screen each time, and keep hitting next. And then when you get to this page, you can hit done. And that will save the progress of whatever you were already able to enter. At that point, I also suggest copying the web address and saving that somewhere, or emailing it to you yourself or your team for the ease of returning to the application. You could also go back to the email that I sent you with the link to the survey, but that's just a backup method to keep track of where you had already started entering. Next, we'll show you a sample application filled out. Next slide. So this isn't exactly what your completed application printout will look like, but for the sake of this seminar, it's easiest to read this way. I skipped the individual responses, question 1 through 6, and started with question 7. So you can see that this grant asks for the full $15,000 possible. The next line item is actually meant to show a total in case you wanted other funding, but it's pretty clear to me that this hospital just didn't need any extra funding, so no worries. That answer is just fine. They've clearly selected their topic, and on question 10, have clearly and concisely named their project. As you complete question 11 and 12, suggest that you have another person unrelated to the project read through them to see if they understand the problem and the planned solution. That'll be a good indicator that the grant review team will also understand your intent and will decrease the likelihood of us coming back for questions after that. Next slide, please. Here we see detail of the project activities and clearly see it's not a quality project, but it is a financial one. And we can see the improvement measures as well. The next 2 slides I took from a presentation where the grant was written typed. I chose this one because the detail, in my opinion, is one of the best that I've seen. So let's review. Next slide. So this looks a little different because, as I said, it's from a previous application version. What I want to focus on is the level of detail in the activities. This is in a clear chronological order. I'll go through them. They have completion of the contract, building the interface, aligning protocols between the person and the system, doing a test phase. Their project goes live and they start collecting data, and then they're ready for their final report. But the flow of the start and the end dates here are aligned really well. As soon as the contract is complete, their build stage begins. Where it makes sense, they have two activities running concurrently, such as lines 2 and 3, where they're building the interface while developing the protocols. Calling out the go live and data collection with matching start dates maximizes the information gathering for both the hospitals to gauge their project success, as well as making it extra easy on themselves once they submit the final report. There were only 2 activities on the previous slide, which is fine, and was an improved project, I might mention. But the level of detail here is going to help both you and the staff supporting the project and the grant review team to see the preparation put into the proposed project. Next. An additional way the detailed project activities can assist you is when the required interim report comes due, usually in March. Are you behind? You can share on your interim report where you are, what caused the delay, and your plan to get back on track. Running ahead on your project, you can still share where you're at and how you were able to achieve your goals faster than you thought. With that, let's return to the new format and finish going through the grant application sample. Next. Each application will be different in the budget area. You can see the sections I mentioned earlier. Some projects will use some or all of these sections. Others might use only one, as is in the case here where they hired a contractor. Next slide. So to highlight, start thinking now of project ideas you might want to do. Consult with staff to see if others are thinking of applying. Please remember that only one app can be submitted per Critical Access Hospital. If you start the application but can't finish in one sitting, then scroll through, hit next on each page and hit submit. You will be able to return to the application, as I previously mentioned, via your computer cookies. The interim and final report format will be very similar to the application we went through today. Please note, successful applicants will also be asked to share their projects and outcomes with their peers. That could mean at one of the regularly scheduled virtual meetings or possibly at the QI workshop. Whether you submit an application or not, whether you run a grant project at your hospital or not, all California Critical Access Hospitals can participate in the annual activities, including the virtual monthly meeting on quality, the MBQIP technical assistance and training, the QHI administration, management and training, the EDTC data collection and follow-up. You can still request the on-site hospital process improvement assistance. And don't forget about that in-person one-day quality improvement workshop in the spring each year. That will support, the grant will support up to 2 people per Critical Access Hospital participating, with most of the costs covered by the grant. And I want to thank you for listening in. I hope you found this beneficial at this time. Next slide. And if there are any questions, I'm happy to answer them.
Thank you so much, Lisa, for all of that great information. We've got some time for questions. We've got about 5 minutes in our schedule today. And we'd love for you to engage with Lisa on all of the questions that you may have. While you're thinking about that, we do have another poll. Go ahead and launch that for you right now. Might stir up some questions here. So help us know where we can best support you.
And then if we go to the next slide, I did include contact information. If you think of a question between now and the launch of the program, or if you have questions while you're completing your application, Peggy Wheeler, who is the lead at CHA for the Flex Grant, she'd be happy to take your calls, as would I.
All right, thank you, Lisa. Leave the poll open for a little bit longer here. We've got plenty of time. Yeah, so far only one of you have answered that poll question. We'd love to get your input on this. In particular, since this webinar is really targeted for the critical access hospitals through our Flex program, this is one of the areas where we really want to make sure that we're supporting you all well and that you're getting your questions answered. I'm seeing a number of people saying that more examples of successful projects and more information on guidance and timelines. Lisa, well, on that note, are there any places that people can go to see more examples of projects that have been done, or to get more information on maybe previous work?
The grants are not published in any way virtually, but I'd be happy to answer questions and offer more examples one-on-one.
Perfect.
If they want to reach out to me at the email or phone number below.
All right, fantastic. Thank you for that. So go ahead and if you're one of the ones that's looking for more examples of what has worked in the past, go ahead and reach out to one of those emails there. We've got about 2 to 3 minutes left before we take our break for today. We're going to do a 30-minute lunch break here at the top of the hour. So any questions that you have, now is the chance to get those in. And I see the other thing that people are saying, more information on timelines. Lisa, is there any advice on the timeline specifically that you would have for people as they're going through their process?
I can't answer when we will have the program in place yet. There are some extenuating factors there, but as soon as we have approval, we will send out an email to go through basically this same presentation as today. So if you would like to start thinking about projects you'd like to do, reach out to me if you have questions. Otherwise, you can start working on it. If you're planning to hire a contractor or know you'll be looking for a company, you could start working on that now. So you already have it ready when the application timeline opens. We try to give at least 2 weeks from the time of the kickoff webinar to the due date of the application, just because we know how busy everyone is, and it'll be new information to some people if they haven't previously gone through the process. But there's nothing that says you can't start thinking about and formulating your project right now.
Absolutely. All right. Well, thank you, Lisa. We appreciate your time today and all of that great information that you brought. Thank you to the California Hospital Association for taking the time to join us today, and for your support to California's hospitals across the state. We appreciate that. I'm going to share the results here. And like I said, we have a break coming up. So let's see. We've got one more plug here for our consultations. We are going to be closing the registration down for that here after we return from the break. And so if you are wanting to get in with our consultations today, please go ahead and register now for that. With that, I'm going to dismiss us for a 30-minute break. We will be back at 12:30 for our next presentation from the California State Office of Rural Health. And so please enjoy your lunch, and we'll see you back at 12:30. The meeting will stay active, and so if you do have questions, you can go ahead and enter those into the chat or the Q&A tool, and we will be around. So with that, we're going to take a pause, and we'll see you at 12:30. Thank you, everyone. We are back for the second half of our Flex workshop, and excited that you're still with us today. Our next session features Eddie Wong from our CalSOAR team, and he's going to give us some updates on everything that's going on in the CalSOAR world. So Eddie, take it away.
Thank you so much, Chris. As he said, my name is Eddie. I am the State Flex Program Coordinator at the California State Office of Rural Health. Lisa gave a fantastic presentation of the Flex Program overview and care grants, but I am here today to update everyone on CalSOAR's activities during the 2025 calendar year. Next slide, please. CalSOAR, in conjunction with the California Primary Care Office, which you heard from Darby earlier today, hosted the maternal health webinar held on March 20th. CalSOAR also hosted the Rural Health Grant Writing Workshop on May 6th and 7th. And of course, we have a list of things going on at the moment, including the Rural Health Transformation Program, site visits, and updating everyone that's subscribed to the Rural Health listserv. Next slide, please. First off, the maternal health webinar. Special thanks to our guest speakers during that event, Javray Valdeparis from the California Department of Public Health, and Lori Link from Plumas District Hospital. Just to recap, the Maternal, Child, and Adolescent Health Office at CDPH shared a number of their programs during that event. The California Pregnancy Associated Review Committee, which is an umbrella that encompasses all of CDPH's programs for tracking and investigating maternal deaths during and up to 1 year after pregnancy, including in-depth reviews to identify prevention opportunities. The Adverse Pregnancy Outcomes Prevention, which is Javray's program, the initiative that was formed last year to support the California Momnibus Act, Senate Bill 65, which promotes health and equity, informs and translates data into action, integrates community-informed prevention opportunities, and enhances the development of strategies to reduce preventable maternal mortality and morbidity. She also shared the Regional Perinatal Programs of California, which is a group of expert regional directors that work with their regional birthing centers to promote standardized, coordinated, integrated, and equitable systems of care systems within geographic regions for pregnant people and their newborns, programs supporting Black perinatal health, and finally dashboards that showed visualizations such as a snapshot of pregnancy-related mortality ratio. Plumas District Hospital advocated for removing the requirement for licensed alternative birthing centers to be 30 minutes in time and proximity from a hospital with a full perinatal unit, as well as other regulatory barriers. Plumas also advocated for a pilot project for some critical access hospitals to establish a standby perinatal service. I'm happy to report that as of October 11, 2025, Assembly Bill 55 and Senate Bill 669 was signed into law. The governing agency for the pilot project for standby perinatal services is with this Department of Public Health. And the pilot project is set for 10 years instead of the 5 years as previously announced. CDPH has until July 1st, 2026 to establish and enact the pilot project, and we'll share more details with you as it becomes available to us. Next slide, please. My colleague, Tiffany Frazier, hosted the in-person State Office of Rural Health annual workshop. Special thanks again to Sylvia Trujillo from the California Telehealth Resource Center and Jay Blackwell from the Vision Design Capacity. CTRC presented on leveraging AI in healthcare, contextualizing AI in healthcare through different prisms, including methods and systems, functionality, level of autonomy, and conditions of employment while advocating for governance oversight to address biases, appropriate training data, and local validation of data and models. The toolkit is available on their CTRC website. HCI Grants Management also gave an overview of the County Medical Services Loan Repayment Program, Allied Healthcare Loan Repayment Program, and Small Rural Hospital Improvement Program. You'll hear more about SHIP in the last presentation for today. Finally, Vision Design Capacity taught strategic framing and guided attendees to choose to improve upon different themes, including expanding interventional services and behavioral health capacity, stabilizing leadership, boosting clinic access, and improving finances. They also guided attendees in advanced usage in AI GPT training to support grant writing. Next slide, please. As you may know, we have been hard at work for the Rural Health Transformation Program, and we're geared to submit the RHTP application for the state of California next week. Next slide, please. Just to recap, RHTP is a provision by Public Law 119-21 that was enacted on July 4th earlier this year. Each state applies for funding. Only one application can be submitted per state, and the entity submitting the application is the state government agency or office designated by the governor, and the application must come with the governor's letter of endorsement. In California's case, Governor Newsom designated HCI to submit the RHTP application. States must invest in a minimum 3 permissible uses of funds, which we'll go over in a later slide. CMS stresses that the funds cannot be used to replace or supplement Medicaid resources. Those funds must touch upon all 5 strategic goals: make rural America healthy again by general prevention and chronic disease management, sustainable access by maintaining patient access to care and establishing long-term access points, workforce development by recruiting and retaining health workforce, innovative care by exploring and advancing new care and payment models, and finally, tech innovation by adopting new or emerging tech or upgrading legacy tech. Now, with the RHTP, CMS is weighing more towards factors like how a state would provide sustainable solutions that aren't capped by a 5-year budget span. They're looking for applications that cross-collaborate with state and local agencies, tribal communities, and even other states. Next slide, please. RHTP funding totals at $50 billion, $10 billion per year for 5 years. Each state will have the opportunity to receive a baseline funding of $100 million a year for 5 years, assuming that CMS accepts the state's RHTP application. Each state will receive additional funding based on various factors. CMS calls that workload funding. We're talking about data factors, such as the state's absolute size of a rural population or a percentage of a state population in rural areas, and other factors such as initiative-based and state policies as written in the state's application. In other words, it's the strength of the application itself. In this area, CMS is looking for applications that demonstrate how the state expands scope of practice, explore alternative payment models, improve remote care, support dual eligible patients, recruit workforce, and etc. It's important to note that CMS will recalculate their scoring of initiative and state policy factors each year, implying that the funding amount is subject to change year to year. Next slide, please. So here's that list of permissible uses of funds I alluded to earlier. You can see that there are you can see that there are categories like prevention and chronic disease, consumer tech solutions, training, technical assistance, and so on and so forth. But you'll start to notice that some of these categories have additional requirements or restrictions, notably category E, workforce with the 5+ year service commitment, category B, provider payments with that 15% limit per budget period, and category J, capital and infrastructure, which is capped at 20% per budget period. Budget period meaning year 1, year 2, 3, 4, or 5. Next slide, please. So as you can see, there were some restrictions there in the last slide, but here's the full list of limitations on this slide. You can see that new construction is completely unallowable unless it's minor renovations capped at less than or equal to 20%. Provider payments capped at 50%. EMR replacement is less than or equal to 5% if a high-tech certified system is already in place. Clinician salaries, reimbursable insurance payments, administrative costs, those either have cap or completely restricted. Most importantly are the consequences of non-compliance. CMS reserves the right to withhold, reduce, or even recoup funding from a state if they determine that said state violated the terms of the program. A key point in violation is failing to follow through on commitments. While a state can reallocate funding to other initiatives stated in their approved application, they cannot abandon an initiative entirely. Doing this will give CMS cause to recoup funding from that state. Next slide, please. Looking at the entire application timeline, each state had 10 weeks to review the notice of funding opportunity, gather stakeholder input, decide the application's direction, draft it, and submit it to CMS with the governor's letter of endorsement. As of right now, we are 7 days away from submitting the application to CMS. As I understand it, we are coordinating with the governor's office to get the application finalized and sent up to CMS before that deadline of November 5th. After the application is submitted, CMS has until December 31st of this year to notify all states of their award amount, and then each state will work with a CMS program officer to monitor the program's progress. Next slide, please. As for what HCI did to gather stakeholder input, we reached out to all California Rural stakeholders that we were able to, and held a kickoff webinar on September 4th to explain the RHTP and the application. Around the same time, we released a 27-question survey for all stakeholders to complete. The survey questions included: what are the most viable evidence-based interventions for prevention and chronic disease management solutions? What are the most viable strategies to improve regional healthcare delivery systems? What are the most viable recruitment and retention strategies? What are the most viable resources to implement and advance alternative payment models? What are the most viable consumer-facing technology solutions? And so on and so forth. We're happy to report that over 350 stakeholders completed the survey with a wide range of respondents. We're talking about hospitals, FQHCs, Indian health services, tribal health, urban health organizations, county departments, local agencies, academic centers, community-based organization, health plans, and more. Next slide, please. So here's a sample of the highest priorities that we identified from the majority of stakeholders in the survey results. We categorized the survey questions and answers to match with the 5 RHTP goals stated earlier. So I can see, as you can see on this slide, with the Make Rural America Healthy Again, we noticed from stakeholders a prioritization for integrated care, evidence-based lifestyle and behavioral interventions, primary care expansion. For the sustainable access category, stakeholders indicated that regionalizing sharing services, hub and spoke networks, telehealth for specialty services are a priority. Stakeholders identified that loan repayment, retention bonuses, and rural residency/fellowship is a priority for workforce development. Upfront funding, support, research, and for alternative payment models and reducing administrative burden is a priority for innovative care category. And finally, tech innovation, stakeholders identified patient-facing technologies such as website portals, reminders, scheduling, text and call reminders, smartphone integration, and remote monitoring as priorities for the tech innovation category for RHTP. Next slide, please. On top of the survey, HCI coordinated 6 listening sessions, 1 for each RHTP goal, and 1 specifically for community health workers. We counted around 900 attendees across all listening sessions. I believe peak attendance was over 250 attendees for a single listening session. The California State Office of Rural Health mailbox received over 100 comments and proposals for our HTP, and we are continuing to receive more throughout the application process. And we encourage everyone to continue to message the State Office of Rural Health mailbox so we can compile and analyze your comments and suggestions. While the application is almost complete, there is still the matter of implementing the initiatives stated in the application after December 31st. Finally, we had a tribal consultation that occurred on October 17th, as well as a site visit in Anderson that occurred last Friday. Next slide, please. We even conducted one-to-one interviews to receive and as mentioned before, listening sessions and proposals from the mailbox. With everything we've heard and read, we've identified consistent priorities across all stakeholders and across all communications format that we did for stakeholders. The consistent priorities, we noticed workforce development, improving chronic disease management and preventing chronic disease, optimizing healthcare delivery, and technology-based solutions to expand and access and promote prevention and management. Additional key input we've noticed is expanding access to care for rural populations through innovative technology and expansion of community-based providers, as well as regional collaboration within the communities to ensure shared resources, best practices, and coordination of services. Next slide, please. So as mentioned earlier, we have until November 5th, next Wednesday, to submit the RHTP proposal. HCI will continue to provide updates through the mailing list. We highly recommend that you subscribe to our mailing list, ensure that the rural health checkbox is selected, and definitely visit us at the State Office of Rural Health webpage within HCI through the website. Next slide, please. As always, CalSOAR has a list of resources that we love to share with you. Rural Health Information Hub is everything that you need to know about critical access hospitals, rural health clinics, even has data visualizations of their own. We frequently collaborate with 3RNet, AHEC, and CPCA, and the Health Professions Consortium, CTRC, and the Office of Binational Border Health. Next slide, please. So that's everything that I can share with you for as of right now. We'll have more activities and more events planned for the 2026 calendar year. Of course, please keep in touch with us at the CalSOAR mailbox address, as well as visiting our website. So thank you very much. I'm happy to take any questions that you have, if you have any.
All right. Thank you so much, Eddie, for all of those wonderful updates. Appreciate all of that information. We do have some time to get some questions in. There's a lot of information there, so if you have any questions, this is a great opportunity to get those answered. As you guessed, we do have another poll for you while you're thinking about your questions. So this one is on CalSOAR assistance, and so pick your top choice here. We know all of these are helpful, but pick the one that would make the most impact for your organization. And we would love to see where your priorities lie. And again, go ahead, raise your hand or type in the chat if you have any questions. We know there's been a lot of curiosity around the Rural Health Transformation Program, a lot of great input and feedback as well. And we hope that you were able to join us for all of the, or at least a portion of the stakeholder listening sessions that we had. All right, starting to see some results coming in here on the poll. Looks like funding and grant opportunities is in the lead, followed by a even spread on the other three choices. Share this poll here in a minute. Give you guys about 30 more seconds to get an answer in. Also about 30 more seconds to get a question in. Oh, looks like we might have a question here. Perfect. Mike asks, what is the best way to apply for one of the grants? Thank you for that question, Mike.
Sure. HCI has a website, has a webpage dedicated for scholarships, loan repayments, and grants. I'm happy to drop it into the chat box right now.
Awesome. Thank you for getting that information, Eddie.
We also have a Microsoft form to check funding eligibility. You follow the form's directions, and at the end, it should let you know what grants that your facility is eligible for.
Excellent. Eddie, did you make a plug for the signing up for the rural health listserv yet?
Yes, I did.
Thought so.
Please go on to the yeah. I'll link that as well.
Yeah, that's one of your best ways to stay up to date with us is be on our listservs. So we'll have more information at the end on those as well. All right, any other questions before we move on?
Wanted to plug in a couple more things. The National Call Quality Assessment is still going on, and the deadline to complete that is November 21st, I believe. And as well, that this entire event, this webinar, what came about from the survey submissions that you submitted with the call quality assessment, as well as Rochelle Spinarski's assessment as well. So please continue to fill out those surveys and assessments, and we'll think of new ideas to provide technical assistance, education, and training on your behalf.
All right, fantastic. Well, as always, feel free to get any other questions you have in the chat, or you can raise your hand as we go on. But thank you, Eddie, for all of that information. We are now going to turn to a live demonstration of HCI's open data portal, focusing on hospital finance data. So I'd like to invite Ty Christensen to join us and tell us all about the open data portal.
All right. Good afternoon, everyone. Pleasure to be with you today. If my name's familiar to you, you probably associate it with being warned of $100 per day penalties for not filing financial reports. Not one of my favorite parts of the job, but this part of actually sharing data is something that is a little more near and dear to me. I enjoy helping people use the financial data we collect so that they can get value from what they've submitted or what the public wishes to see. And so I just gonna go through a couple demonstrations of some of our newer products to give you some idea of how you could use our data in your work. I believe there's an intro slide. Next slide. So yeah, so this talks about our mission that we're to expand equitable access to healthcare for Californians and ensuring that they have the workforce and safe health facilities and health information. So that's our area of focus is the health information. We collect various reports. My focus is the financial reports. And actually, I think we need to update this slide. We are now collecting our 50th year of the hospital annual financial disclosure report and reviewing those reports. So we're at 50 years now and been going strong. Next slide. So purpose here, we're going to demonstrate a couple data products. I hope to do one that I may not be able to do today because we're having an Azure issue, I guess a nationwide outage of Azure, but I'll pivot to something else and offer some tips on using those data products, and hopefully that will just help you to have better transparency into not only your facilities but other facilities and throughout the state, the overall cost transparency, and just being able to use these data products and visual platforms and some of the highlights of some of the most commonly used financial data items. So I think this is where I will take over sharing my screen. So if you'll wait a moment here, I'll get this open. Okay, so I believe you should be seeing right now our internet website for HCI. This is the landing page you would come to the website, and I just wanted to show you how you would get to our data products. We've got this tab up here, or menu item data. Usually the people I deal with are submitting data, but in this case, we are actually going to one of the topics. And so cost transparency has various different cost transparency data programs in it. And so I'll go to that. And you'll see our various different cost transparency programs. My focus is on the hospital financial, long-term care financial. I have previously worked with various of these: RX, supplier diversity, community benefit, charge master, fair pricing. I've been around a while, so a little bit of everything. But I'm going to just focus mainly on the hospital financial, given the short time we have today. And just show you some highlights of some of our newer products and visualizations and how you could use that. So I will go to that topic. And here you'll see we have our hospital annual disclosure report and our quarterly financial utilization report and various products from that. So this is just kind of a listing. This will navigate you further down this page where it will talk a little bit about each of these products. The individual reports, I encourage, whenever someone's using our data, I always encourage them to look at the report, especially if you're trying to use the larger data sets. We have some very large Excel files. We have one that's 18,000 columns, one row for each hospital. It's everything on the annual financial disclosure report, and that can be pretty overwhelming if you don't see how the data is submitted in context. So that would help you if you just look at an individual report, download that as you're using data to have just a bearing of seeing the data in its natural format of the submission. It's a pages of forms, and it gives you context to that. Today, though, we're going to go to annual financial disclosure trend reports. This is one of our newer programs. We have a interactive hospital financial visualization series. So this is going to take our selected data file from the hospital annual financial report and present it in some visual presentations on our website that are interactive. So as I open that, this is the landing page for this new visualization series on the hospital financial. It has three categories that we've kind of separated data into: hospital financials, just kind of straightforward financial data, a little more about hospital utilization, and then this hospital average cost and profitability, delivering patient care. This does a little more standardizing of revenues and costs, and we'll get into that as I demonstrate the product. But for now, let's go ahead and just look at the first one, the hospital financials. And so you come in, it's got a table of contents for this page. It gives you an introduction. Within the introduction, there's a link to get back to that initial page where you can select among the three topics. And then there will be an actual, let me get this scrolled so it fits within the page, an actual visualization based on the data. Currently, we are using audited data, so there is a bit of a lag. We are currently getting the 2023 into this tool. All the 2023 reports have been audited, but it won't have the most recent 2024 in this particular tool. We have some other data products that would get you to that more recent data, but this is showing you what we have for this through 2022. There are different tabs for different data, so this chart will change as you choose different tabs. This one's not the most glamorous, it's just total assets of all the balance sheets that are submitted by hospitals. On each of these tabs, there will be a detailed information tooltip that you can look at that will give you information about what you're looking at on that. So if you hover over that, I don't know if you're seeing that because it's a pop-up, but it'll give you just information about the charts that you're looking at. Within this tool, you can choose selections to look at more granular aggregates. Right now, it defaults to all of the state, all the hospitals in the state added together. You can choose a county, a city. You can choose a type of control, which would be your city, county, district, investor, nonprofit. You can mix and match these two. So you could say, show me all the nonprofits in LA County, or you can pick an individual facility from this list, and you can actually pick multiple facilities if you want. So if you want to pick 3 facilities and see what they look like added together, this will do that for you. It'll add their data together and present that in the visualization. The teaching rule option. Now, many of you may be familiar with there's a statutory definition of small rule. It looks back to a 1982 peer grouping. It's used for exemptions in statutes for certain reporting. It's used by DHCS to determine QOF payments and reductions for rural facilities. So this is what we've typically always included in our financial data products is that peer grouping rule definition. It doesn't match the rule definition of facilities that's going to be in things like the Rural Health Transformation Program. We're considering changing that to be more consistent with more up-to-date, not 1982 rule definition. But we will maintain the peer grouping 1982. That is what we will share with the HCS. They will still be working off this. We won't take someone's rule designation away, and so they won't lose that QOF funding or various other safety net financing things that depend on that. So we will continue to maintain that, continue to provide that in our data sets, but on these visualizations that are more public oriented, you may see this category change a bit in what is included in there. So this, as you see, it just shows you the total assets over a period of time and how they've gone up. And many of these then will have a breakdown of those items for a single year. I'm going to stay on state total. I don't want to pick on any individual hospital or pit nonprofits against districts and stuff. So I'll just stick with the total and not do a deeper dive into individual one. But it would basically just adapt for what you've selected up here. These are alphabetical order. So if you're familiar with balance sheets, you kind of expect current assets to be up top, but it's construction progress up top. But it'll just show you those amounts for the different categories of assets of a facility. Second chart here, uncompensated care. That's going to be a little more near and dear to people's hearts because there's, a lot of uncompensated care that hospitals are giving. And so this will show you a chart of that, again, over time. And then we do a uncompensated care cost. So this is by taking the write-offs of accounts receivable that were written off, using the cost to charge ratio to come up with this is how much cost of the hospital that they spent money and didn't get reimbursed for. So it breaks it down by bad debts, charity, and then county indigent programs. Within this, if you want to go back and say, oh, 2018 or 2017 looks interesting, let me switch that. It will switch this as well. And as you move between these, you also maintain any selection you have up here. Again, I'm sticking with the not selecting, so it'll always be state total. But you can then move to revenues and expenses. Again, not a really big graphic chart. It's just the one chart we have, just showing revenues, expenses over time. You can see how many facilities have reported and stuff by hovering over. And obviously the trend of operating expenses being more than net patient revenue. This next one, operating margin. Here, I'm going to go ahead and make a selection because this tool will actually, and I'll do LA County. That's the least likely to be identifiable to one. This will actually do a comparison. So whatever you've selected up here, maybe it's a single facility, maybe it's a type of control, it will show you your selections, operating margin, trend line, and the statewide average. Now, LA County is a big driver, so it's pretty similar because they have so many of the hospitals, but some others selections you make may be very different than this one. And so that just kind of shows you the downward decline other than just before the pandemic. But yeah, that shows you the operating margins of hospitals. And the last one does the same thing. This is just cost to charge ratio, not one of the most exciting numbers, but just kind of like the little slightly downward trend of the cost to charge ratio. So that is the financial category. Let me go back and show you quickly the utilization category. Again, it's going to have the same look and feel as it loads, where you can make your selections. You've got the information on this button here to show you what you're looking at on each slide, and that you could look at the different categories. Total licensed beds don't change a lot. Small downward trend as facilities close. And then breaking those down by type of care. And so you can pick a different hospital, and I'll show you, how many beds they have by type of care, or you can pick a type of control or rural hospitals, and those will all adapt to your selections. Patient discharges. Here you'll see, again, the total. We then break these down also by type of care: acute, ChemDep, long-term, psychiatric, rehabilitation, and residential, and then by payer categories. If you're familiar with our data, we use a term traditional, which is typically fee for service. Our traditional managed care breakout goes way back decades when managed care was new. So this will just show you how many discharges by each of the typical payer categories that we collect data on. Same thing on patient days, total patient days by type of care, and patient days by payer. And then outpatient visits, total, and again by each type of payer. And those are some of the utilization. Now we're going to go over to, this is based on our labor productive hours reporting. So we collect productive hours worked by employees within each hospital. And then we don't collect counts of employees, and we try to standardize it by using what we call full-time equivalents, which is basically 2,080 hours. It's 52 weeks times 40 hours a week, because there's so many combinations of staff who work 32 hours, 36 hours. And so this just kind of more standardizes it as to number of hours, or average hours for a full-time equivalent, so that when you're doing comparisons between hospitals, you have a little better comparison of how much productive time is spent working by these different employees. We break these down then by the classification of employees. So we have aides, or again, alphabetical. I know registered nurse should probably be up front because that's your biggest bulk, along with a technician and specialists. But aides and orderly shows up first, all other clerical, food service, LVN, management, and then of course your RNs and technicians and specialists being the bulk of the labor. We do collect total surgeries, a little bit, inpatient, outpatient surgeries. So it's not a really big graphic. You kind of see the decline in 2020 that we're all familiar with, and it coming back up 21, 22. And then average length of stay of a patient in the hospital. And again, the general trend, it was staying stable, and then along came the pandemic and it surged up a bit. So that's the utilization. And then finally, I will go back to the, this was going to be the one that's a little more able to compare data because it standardizes the data. All right, so this is the first chart, gross patient revenue per adjusted discharge, gross patient revenue being your full established charge, not what you're going to collect in almost every case. But it does kind of give you, this is the trends of gross patient charges per adjusted discharge. Now, adjusted discharge, meaning we've adjusted for outpatient volume by using the gross charges. If you're familiar with the work that the Office of Healthcare Affordability is doing, they also are using adjusted discharges, but they're also adjusting by case mix index using our patient level data for acuity of patients. This is not doing the case mix index because that's a different data source. And so this is just coming straight from financial data. And so this is only adjusting for different various levels of outpatient activity so that you could then compare between one hospital and another that may have more outpatient activity than the other and still kind of standardize that. But it'll show you the gross charges per discharge, again, broken down by each payer. And this is, like I said, the gross charges before any deductions for what actually will be collected. But our next graphic, net patient revenue, does the same thing per adjusted discharge, but this is actually what's expected to be collected. If you're familiar with accounting, it's estimated at the time of service. You estimate how much deduction you have, and then those are, periodically analyzed for accuracy to make sure they are accurate. So it's pretty good, close to what the actual cash payments will end up being. It's just a little bit more of an estimate at the time of service that the revenue is booked. But it'll show you how the revenue, net patient revenue per discharge has changed over time. Again, you could look at each of the payers. You can go back to a different year. That chart changed quite a bit when I switched to 2018. But you can do different analysis as you make your selections on different facilities to see some of that variation of what you get paid depending on who the payer is. Operating revenue, again, just total operating revenue. So what this adds, it's the net patient revenue, what you're getting paid for your care, including any supplemental payments. And then this adds in other operating revenue. It could be cafeteria sales, it could be parking revenue, things like that are normal for operating a hospital, but they're not derived from caring for a patient. So it just adds in that extra amount from what we had from the net patient revenue. But this then would compare a little more to operating expenses, which also includes cafeteria expenses, parking expenses, parking lot, things like that. And so that shows you the trends over time for those. And then finally, operating income. And this one, I'm going to go ahead and show you, not to judge a county, but just to show you that if you have negatives, it will show in negative operating income per adjusted discharge. So this is per every patient's stay, typically inpatient, although adjusted for outpatient activity. This is how much is earned or lost per each patient. So you could see, on average in Alameda County, they lost $1,600 per patient for every patient that stayed in a hospital in 2022. That is this visualization series that we have. with a little time left, I am going to go to a tool that you probably may have heard of, you may use, called our Pivot Profile. This, you actually would go to the Open Data Portal and you could download. It's an Excel file. It's a little archaic to some people. It's not user friendly, but you could download the 2024 pivot table. I've already done that. Let me switch my screen. And it'll come up with some warnings because your Microsoft doesn't like downloading complicated Excel files. If it doesn't want to enable the macros, that's okay. You can use it without the macros, enable editing, things like that. But this has been a popular tool for decades. CHA loves to quote this. They even put it in statute recently. So yeah, it allows you to do some of the same aggregations on a single year of data. So this is the 2024, so definitely more current on a single year of data. Again, you have your selections. You can choose a hospital. You can also select multiple hospitals if for some reason you want to take the 3 closest hospitals to you, select those and add them together. You can do that. County, health service areas, type of control, ownership type of care, whether or not it's a DISH hospital for DISH payments. Again, that 1982 peer grouping teaching or rule. Also common for rural hospitals is you may have higher skilled nursing because you have a skilled nursing facility attached to the hospital as a distinct part. This has ranges of skilled nursing so that maybe you want to look at hospitals with the same range of patient days, that maybe over 75% of their patient days are skilled nursing. This will group that together. So you make your selections here, and then you switch over to this profile tab. And this basically goes, it gets the data, and then formulas populate this with just a whole rich different sampling of data from the annual financial report, where you'll be able to see various things by type of care, beds, occupancy, patient days, discharges, average length of stay.
I'm sorry, Ty. I'm afraid we only still see the website.
Oh, I am so sorry. Let me reshare. You see that now?
Yes,
You
thank
see
you.
it? Okay, sorry. Okay. Should have jumped in quicker there. But yeah, so sorry, I was going through this is where you make your selections. And I was saying that the LTC day percentage is kind of crucial to hospitals that have a distinct part skilled nursing where they can compare to others in their area that might have the same percentage of skilled nursing. And you could select multiple hospitals if you wish to select, the 5 in your area or whatever. And do your selections here. And then when you come over to the profile, you'll see the results of that selection. So if you pick a single hospital, it'll show the data for just a single hospital. If you've picked, whole hospitals with more than 75% of their patient days are long-term care, it'll show the summation of all of those hospitals on this tab. It'll have the little profile characteristics here, kind of mid right, that bottom right, that shows what you've selected on another tab, just so you have a reference to know when you look at the who is included, breaking down things by the type of care. It'll give you an income statement, and it'll do this. Now, we typically used to do things per adjusted patient day. Again, adjusting for outpatient volume. Things have moved a little more toward adjusted discharge for a whole patient's care. This initially was more looking at efficiency of caring per day, but length of stay comes into play to that. But so this is more per each patient day of what you do, and then of course the idea is that you could then compare this to other hospitals and say, okay, This is our net patient revenue per patient day compared to theirs. This is our non-operating revenue compared to theirs, or whatever comparisons you have. A bunch of financial ratios that have been calculated for you, current ratio, days in accounts receivable, various ratios used, total margin, net income margin, just to have those performance ratios. Deductions from revenue, all the money from your gross charges you're not going to collect, capitation premium revenue, a summary of other utilization statistics such as ER visits, clinic visits, home health referred, surgeries, your nursery activity with natural births, C-sections broken out, dish fund transfers. If this facility, well, this is state total because I didn't pick a facility, but this is money equity that was transferred for matching in the dish fund. So this is not included in net income. This is an equity transfer. So some people like to say, yeah, but when you take out what we had to transfer in equity from net income, the cash flow was less because we had cash flow out. Let me scroll down. Then we go into a kind of profitability by payer. You can see where we've got the total for the facility and then the various payer categories between traditional and fee-for-service and managed care. And we've taken some of the activity and the gross revenue and the deductions, plus the capitation premium revenue, to come to the net patient revenue. And then we've done an allocation of expenses based on the gross revenue for each, saying, okay, each of these payers had some of the operating expenses assigned to them. And then you could see whether there was a payment shortfall or surplus. We'll call it a payment shortfall. Just leave it at that. Politically, some people don't like to say that for Medicare, but you'll see, if it's negative, it's coming up short to cover the hospital's operating expenses. And then we'll do that again, standardizing per adjusted patient day to see how much per patient day that is. And you can look at the different payer categories for each of those. A balance sheet, just showing you again the breakdown of the balance sheet, current assets, current liabilities, percent of total. If you want to do some more in-depth, how much cash there is, total property, plant, equipment, intercompany receivables and payables that are included in there. So a little bit of detail on that. And then again, going back to that labor being the driver of costs in hospitals, we've broken down what we have in the costs of labor, again, by the classification of employees, where you can see the total amount paid, how much it is per adjusted patient day, the percentage of the total labor expense or of each of these expenses. So labor, you see salaries and wages, 33% of the total expense, employee benefits, 14%. So you're talking 48% is directly to labor. And then you can see the other categories, purchase services, depreciation, leases, and rentals. So all the different classifications of expenses. And then also those expenses by groups of cost centers. So your daily hospital services, your inpatient care services, your ambulatory, ancillary. If you're purchasing inpatient, outpatient services from another facility, research, education, general services, fiscal, admin, and any other unassigned. So just a breaking down of how those costs of a hospital break out. And then further drilling into the salaries and wages and stuff, we have the productive hours worked by each employee. So this is not paid time off. This is just the hours worked. And you can see the classifications, how many that hours per patient day are worked, the percent of the total hours worked, which classifications they're in, bringing in that productive FTE amount again. And then we even go down to an FTE per occupied bed to look at how many productive hours per occupied bed is spent per day. So 5 full-time people, basically, per every patient in the hospital. And then we do have a total for paid hours, not broken down by classification. So this would include the paid time off in total paid hours. Lastly, if you did pick one facility, it would give you these key information characteristics about that facility. I have the state total, so I'm not going to pick on one facility, but it would give you all their information from the financial report about that facility. All right, so that was a lot of numbers to go through after lunchtime. But if we got a few minutes, we can open to any questions or answer anything that might come up.
Thank you, Ty, for that thorough and informative session on all of the data portal capabilities and more. Let's see, we've got a poll, I believe, to start us out with this section. Here we go. As you guys think of your questions for Ty, give us a little bit of feedback on what additional feedback you need, additional training and resources. And again, if you have any questions for Ty, go ahead and raise your hand or enter the question into the chat, and we can get those questions answered for you. Leave the poll open for a little bit longer, make sure everybody gets a chance to get their input in. And any questions for Ty today? He covered a whole lot of information, so there's likely to be at least a couple questions out there on everything that he shared. It looks like so far I'm seeing a good mix of answers to the questions. We'll go ahead and end the poll here and share those results so everybody can see. Got 40% of you saying, yeah, we would like to get some more technical assistance and training. 20% saying maybe, and 40% saying we got this. So, all right. So it looks like we got a good range of experience and confidence in the open data portal. All right. Well, what we're going to do is we're going to take a quick 3-minute break here before we start our next presentation. Ty, thank you so much for everything that you brought to us today. And again, if you have any questions, you can always shoot us an email and we'll be happy to connect you with the right person to get your questions answered. So 3 minutes and we'll be back for our presentation on the Small Hospital Improvement Program. All right, thank you. I just realized I was muted. I apologize about that. Our final session today will be led by Matthew Garcia, who will provide an overview of the Small Hospital Improvement Program, including the funding opportunities and the upcoming deadlines. And with that, I will hand it over to Matthew to talk about SHIP.
Thank you, Chris. I appreciate it. Thank you and welcome everyone for joining us here today. First off, my apologies. I am battling a cold and it finally got the better of me. So if I sound a little congested nasally, I do apologize. I'm working through it as best I can. As Chris stated, I'm going to be presenting on our small rural hospital improvement program. And without further ado, we can get right into our presentation. Excuse me. So, general program overview for the Small Rural Hospital Improvement Program, again, SHIP, offers grants to eligible hospitals to support activities intended to improve quality of healthcare in rural areas. Our goals are to assist small rural hospitals in meeting value-based payment and care goals through investments in their hardware, software, and training programs for those systems. The program is fully funded by the U.S. Department of Health and Human Services, Health Resources and Services Administration's, HRSA's, Federal Office of Rural Health Policy, FORP. Next slide, please. Hospital requirements for this program are that they must be located in the state of California, outside of a metropolitan statistical area, an MSA, or in a rural census tract of said MSA. These must be non-federal, short-term general acute care facilities, staff 49 or fewer beds, and must meet federal priorities as specified in the yearly application upon submittal. These hospitals may be for-profit, not-for-profit, tribal, and faith-based hospitals. In addition, critical access hospitals are automatically eligible for this program. Next slide, please. Our funding and award information. The SHIP program runs on a one-year grant basis from June 1st to May 31st of the following year. Funding and award amounts are announced each year by HRSA after receiving all applications. The annual award amount is estimated to be around $13,000. That number could be a little bit higher, could be a little bit lower, but in general, it's around $13,000. And that is based on the number of submitted applications as well. Every eligible approved participant hospital receives the same award amount. Continued yearly funding for the program and active grants is dependent on receiving federal funds. So as stated previously, this is a fully federally funded program. If, unfortunately, we are not awarded funds from the feds, then in that case, we would not be funding the program for that year. Luckily, we will be this year. Next slide, please. Our current application cycle and important dates to remember. For this year, our application will open on December 1st. And we will be having a technical assistance webinar for that application on December 15th. The application cycle will be closed on January 30th, 2026. And by March 20th, 2026, final work plans and edits and corrections for any submitted application will be due. And by June 1st, 2025, the program will begin its next grant year. Next slide, please. For our application process, excuse me, applicants and continuing grantees must complete an annual online application. In order to do this, you can log in with your user account via HCAI's funding portal, and all applicants and continuing grantees will provide certification or recertification that they meet program eligibility requirements, select allowable projects that they anticipate and will complete in the next program year, excuse me, complete detailed work plans for each selected project, provide a midterm update on project or projects that they've selected for that current program year. This is for our continuing grantees only. And below you can find our funding portal website. You can always reach out to our SHIP program general inquiry inbox as well if you do need that website link. Next slide, please. Excuse me, one moment. Apologies. The application review process is as follows. After applications are submitted, HCI staff will review each application for its eligibility as well as project eligibility. If edits are necessary, HCI staff will contact whoever is listed as the contact or director of their hospital, and we'll return the application to you as in progress so that you have the ability to make edits. Due to federal deadlines, failure to submit necessary final edits by March 20th, 2026 may result in a loss of grant funds for this program year. So that is an important date to please keep in mind when submitting edits to us because we are working on federal deadlines, not our own. It is imperative that you get us all corrections necessary by that date so that you do not miss out on this year's grant award. Participants who do not receive grant funds for this program year will still be eligible to participate in future program years. So if you do fail, unfortunately, to get those edits to us, that would not disqualify you from the following year, but it would disqualify you from this current year. Again, if you do not have, in addition to a qualified project, or you choose not to participate for whatever reason, that would also not disqualify you from a future program grant year. If no edits are necessary, HCI staff or SHIP staff will contact you to confirm your application has been approved. Next slide, please. Are allowable project categories as part of your application. Eligible hospitals apply for the funding to assist in the implementation of activities related to the following: value-based purchasing and investment activities. These are activities that support improved data collection, facilitate quality reporting, and improvements. Accountable care organization or shared saving investment activities. These are activities that support the development or the basic tenets of ACOs or shared savings programs. And finally, payment bundling or prospective payment system investment activities. And these are activities that improve hospital financial processes. Next slide, please. Next. Apologies. Specifically regarding value-based purchasing, these investment activities include quality reporting data, collection and related training or software, MBQIP data collection, processes, and related training, efficiency or quality improvement training in support of VBP related initiatives, provider-based clinic quality measures education, and alternative payment model and quality payment program training and education. Next slide, please. Payment bundling or prospective payment system activities include ICD-11 software training, ICD-11 software and training, efficiency or quality improvement training in support of PB or PPS related initiatives. That includes the S10 cost reporting training and price transparency training. Next slide, please. Forgive me. Accountable care organization. The accountable care organization or shared savings investment activities include computerized provider order entry implementation and training, pharmacy services training, hardware, software, and machines, not necessarily pharmacist services or medications. social determinants of health screening and software training, efficiency or quality improvement training in support of ACO or shared savings related initiatives, systems performance training in support of ACO or shared savings related initiatives, mobile health and telehealth hardware software. This does not include specifically the telecommunications aspect. Community paramedicine hardware and software training, and health information technology training for value and ACO, including training, software, and risk assessments associated with cybersecurity. So in all these, you'll notice there's a lot of software, hardware, and training for them. And it's what we really try to emphasize for your programs to make your programs and your hospitals hopefully run more efficiently and quickly to lessen the burden of what we know is a lot of tech-related issues. Next slide, please. Our award process is once HCI has approved your application and the applications have been approved by and for the FORHP. That'll be done by April 2025. Eligible applicants are awarded if said funding is available, again, around $13,000 or so annually. The final award amounts are determined by FORP after reviewing all submitted applications. HCI, we will reach out to contact applicants and grantees with that award information when it becomes available. Awards are paid out at the end of each program year after each participant submits a year-end report confirming completion of their selected projects. Again, to emphasize, please note that we will not issue payments until after receiving that year-end report. So it is imperative that you get that report to us as soon as possible, as soon as your grant date ends. Next slide, please. The yearly program priorities. The Federal Office of Rural Health Policy, FORP, announces annual yearly program priorities. SHIP participants are expected to show they're meeting these priorities with or without the assistance of SHIP grant funding. For program year 25-26, the priorities were Medicare Beneficiary Quality Improvement Program reporting, ICD-11 training and software. And these priorities may change for each program year. Applicants will be informed if these priorities change. Next slide, please. And thank you very much. That is the high-level overview of our program. As always, if you have any questions, please contact our general inquiry inbox, and we'll be happy to assist you in any ways that we can. We are here for you. Again, a few notes. Please note that this program is entirely federally funded. So, if we unfortunately don't receive funding, then this year you wouldn't. We don't expect that to happen, but it is something to keep in mind. And again, please keep in mind our application open date and close dates, and to make sure that we can get your applications processed as soon as possible. And if you guys have any further questions, we're happy to take some time to answer any that you have. Thank you.
Thank you so much, Matt, for your presentation on the SHIP program. And as you guessed, we have a quick poll for you here to let us know what resources and help you need for SHIP. But we do have plenty of time today if you do have other questions for Matt regarding the program and how you could be a part of it. And again, it looks like we're seeing a good spread of engagement here as far as the different resources that are needed out there. I'm glad that you're all here. All right, let's share those poll results here. Looks like we're looking for especially the guidance on funding application and the examples and staff training. And a couple of you are SHIP professionals and know exactly what you're doing, and so we appreciate your participation with us, and means that you've been around with us a few times, and we're glad to have you still with us. All right. Any other questions that we have for Matt regarding SHIP? Give about 30 more seconds here for any questions you have. All right, Matthew, thank you so much again for your help and everything that you do on that program. And with that, I'm going to open it up for one last chance for any questions. This is the end of the webinar today. We can go to the next slide. And the next one after that. We thank you that you joined us today. We talked about a lot today. We talked about the Seismic Compliance Plan and the Small and Rural Health Hospital Relief Program. We had a session on the health professional shortage area designation process and benefits. We talked to you today about the Flex Care Grants and critical access hospitals. We got some updates from the California State Office of Rural Health, in particular on the Rural Health Transformation Program. We saw a live demonstration of HCI's open data portal and hospital financials. And then Matthew rounded us out today with the Small Hospital Improvement Program. So we did cover a whole lot today. Before we let you go, we've got a couple reminders and then a couple resources. Just a reminder that we are recording this today, and we will be posting this on our website within 10 business days. If you didn't have a chance to get a one-on-one consultation and you still wanted to get that help, please feel free to reach out to our contact list here. And we'll keep this up for a minute here for you, that information. This will also be on our webpage as well when we get the recording posted, and so you'll be able to get this information if you need it later. We encourage you to share what you've learned today with your teams and continue engaging with us throughout the year. And to do that, we've got a few different resources that we would love for you to be aware of if you are not already. First off, we have these websites and resources that we know that you're going to find helpful as you go through all of the things that we talked about today. Again, this will be posted on our website. And then next slide. We would love for you to follow us. Please go to our website to see all of the great resources and programs that we have. Also follow along on our social media channels. We would love for you to tag us on any great work that you're doing that's helping make California a healthier state. And so we would love to see that in our social media feeds. And if you are not yet, we highly encourage you to sign up for our monthly newsletter. You can go to the link here. We also posted that in the chat. We can post that again. And all you need to do is for any of the health workforce sections, click on any of the boxes under the health workforce section, and you will be added to our mailing list. For this group in particular, we encourage you to sign up under the rural health box, and that will get you on that list as well. And you can always call us or email us. In particular, please email us at calsorh, CALSORH, at hci.ca.gov, and we'll be happy to help you out. Well, thank you so much for joining us today and for your continued commitment to advancing access and care in California's communities. We look forward again to connecting again with you soon. We thank you for joining us. And with that, that does conclude today's webinar. We hope you have a wonderful day.